and for organizing such a wonderful summit on pulmonary function testing. Life starts with the first breath and ends with the last breath, isn't it? And the period between the first breath and the last breath is what we call life. Most essential thing in life because it nourishes our body with oxygen. Various tools have evolved over a period of time, and we're going to primarily talk about spirometry in this session, but equally important are all the other sessions that will follow over this. But spirometry at the end of the day is the base lung function test that each one of us must be associated with or must be expert in, because that is a fundamental test that we do to understand lung function. Can I have the screen over here? How do I go to the screen? Okay, so what I'm going to talk over the next 25 to 30 minutes is on the basic principles, the standards, and the interpretation of spirometry. And I hope that each one of you sitting in this hall, at the end of this talk, should be quite confident in understanding what is spirometry and how to interpret it. The term spirometry originates from a Latin word that contains spiro and meter. Spiro means the air, and meter or metry means to breathe or to measure. So measurement of the air that we breathe is what is called spirometry. It was invented by Sir John Hutchison way back in 1846. It's a very interesting story. Sir John Hutchison was born in Newcastle upon Tyne in the United Kingdom, and then subsequently became a physician with Britannia Medical Insurance. And as a medical insurance doctor, his responsibility was to perform tests that would predict how long each one would survive. And based on that, have a premium, health premium, insurance premium. And with all the other tests that we do, like blood pressure, ECG, blood sugar levels and all that, he believed that spirometry was the best predictor of how long you're going to survive. And that volume of air that determines how long you're going to survive was what he called as vital capacity. Why did he call it as vital capacity? Because he was able to show through his research that that volume of air was vital for survival. And therefore that term vital capacity was introduced. What is vital capacity? Take a deep breath in, fill your lungs with as much air as possible, and then remove all that air out. Whatever amount of air you remove out from the lungs is called vital capacity. Now, if you remove that slowly, you would call it as slow vital capacity. If you remove it with force, you would call it as forced vital capacity. So I have already introduced to you all three terms: vital capacity, slow vital capacity, forced vital capacity. The stethoscope was just invented at that point of time, and he was able to show that spirometry was even more sensitive in diagnosing tuberculosis than what the stethoscope could do. And as I said, that he was an insurance company medical officer who believed that vital capacity was the best predictor of survival. For about 100 years, that was the only lung function parameter that was used. So the device that he used to measure this vital capacity was called as a spirometer, which is a water-sealed drum. After about 100 years, knowing that vital capacity values do not change much between a healthy individual and a patient who has got a lung disease such as mild or moderate obstructive airway disease. If you have a severe obstructive airway disease, or if you have a severe restrictive lung disease, obviously the vital capacity values will change. But in patients with obstructive airway disease, those who have mild to moderate disease, the vital capacity values do not change much. So there's no application of FVC or VC in diagnosing obstructive airway disease. 1945, 100 years later, a French physician called Tiffinot, he was able to show that if you measure the vital capacity with a time domain, in the sense whatever volume of air you can remove in the first 1 second, you compare that with other people. So that portion of air that you remove in the first 1 second over a period of time is what he called as FEV1, forced expiratory volume, in the first 1 second. And this FEV1 was different in patients who had obstructive airway disease compared to those who are healthy individuals. So for the first time, we got a signal on a lung function test that predicts whether you are healthy or whether you have an obstructive airway disease by measuring the time component. Okay? And then over a period of time, the ratio between FE1 upon FVC then became established as a diagnostic cutoff value for obstructive airway disease. So FE1 upon FVC became the diagnostic cutoff ratio, and that was 70%. So what is the fundamental principle behind which a spirometer works? The main function of a spirometer is to diagnose obstructive airway disease. That is the most important application. 90% of the time you would perform spirometry to diagnose obstructive airway disease. So what is the principle that it uses? If I ask you to take a deep breath, fill your lungs with as much air as possible, and I give you a big straw, and I say remove that air as fast as you can through the straw, the big straw. Then I ask you to take a deep breath again, fill your lungs with as much air as possible, and give you a small straw. And I say, remove all that air out as fast as you can. Through which straw do you think you will be able to remove the air faster? The bigger straw or the smaller straw? Obviously the bigger straw. That's the fundamental principle. As the straw becomes smaller and smaller and smaller, it will take you longer and longer and longer to remove the same air out. And let me show that to you in a simple animation format. So here is a healthy individual. I've just clubbed all the alveoli together into one big alveolus, and then all the airways into one big airway. And you can see that there is the lumen is nice and big and patent. You can't see my pointer. So the lumen is nice and patent over here. So this is nice healthy airways. Now this person has taken a deep inhalation, filled the lung with as much air as possible, and I say blow out. See the amount of time that it takes to empty the lung. Did you see that? Now I will show you what happens in a patient with obstructive airway disease. So here you can see that the lumen has got obstructed. Person has taken a full deep breath, and I ask this person to blow out forcefully. See what happens. The big straw and the small straw. As simple as that. So this is the fundamental principle behind which spirometry diagnoses obstructive airway disease. Once again, to show you what happens in a healthy individual as fast as possible. And if you convert this into a graph where you have volume on the y-axis, then the maximum volume of air that you removed out is what we call as vital capacity. And because it's removed with force, we call it as forced vital capacity. And now if I give it a time domain, that vital capacity, the portion of that which I remove in the first 1 second is called as FEV1, or forced expiratory volume in the first 1 second. Volume of air that I remove in 2 seconds is called the FEV2, and 3 and 4 and so on. Now there are two very important observations that I would like you to make in this. One, the volume of air that you remove in the first 1 second is always more than 70% of your total vital capacity. Always more than 70%. And number two, if you look at the time when you reach the plateau, what is a plateau? All the air has come out. There is no more air left to come out. How much time does it take for all the air to come out from the lungs? Around 2 to 3 seconds. So after around 2 seconds, you get a flat line. And this flat line is called as a plateau. So in a normal healthy individual, the plateau starts appearing at around 2 seconds. Between 2 to 3 seconds, around that time. It takes only that much amount of time to empty the lungs. After that, it's a flat line. Now, when you want to compare this with what happens in a patient who has got obstructive airway disease, so just to revise the animation, as you can see, it takes a long time for the patient to remove the air out from the lungs. When you convert that into a graphical format, vital capacity, as I said, in patients with mild to moderate obstructive airway disease doesn't change much. So that doesn't help you differentiate between presence of obstruction or no presence of obstruction. But on the time domain, see what happens. The volume of air that you remove in the first 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, and 6 seconds. What is the difference between the first slide and the second slide? Here, the volume of air that you remove in the first 1 second is less than 70% of your vital capacity. And second, when is a plateau reached in this patient? In a normal healthy individual, the plateau is reached at around 2 to 3 seconds. Here it is taking a long time for the plateau to reach. This is how you differentiate and diagnose obstructive airway disease. So spirometry is all about measuring these two important parameters, FVC, FEV1, the ratio between FE1 upon FVC, and so on. I'll tell you the two other parameters. So the first graph that you get in a spirometry test is called as the volume time graph, where you have volume in the y-axis and time on the x-axis. Volume is measured in liters, time is measured in seconds. The volume of air that you remove in the first 1 second, this portion, this is called as your FEV1, and the maximum volume of air that you remove from the lungs is called as FVC. So on the volume time graph, these are the two important parameters that you get, and FET is the one for how long did you do the test. So if you stopped over here, then you blew for about, say, 7 seconds. Then your FET becomes 7 seconds. So the volume time graph is the first graph that you get in spirometry. The second graph that you get in spirometry is called as the flow volume loop, where we have the flow on the y-axis and volume on the x-axis. Mind you, in the volume time graph, volume is on the y-axis. Volume is on the y-axis. In the flow volume loop, volume is on the x-axis. So the point that is furthest to the right then becomes your FVC. This becomes your FVC volume. And the highest flow that you have removed from the lungs, the peak flow, is called as the peak expiratory flow rate, the same value that you get with a peak flow meter. Okay? So this is the peak flow, this is the FVC. Now if you divide the forced vital capacity into 4 quadrants, so this is 50% of the FVC, 25% of the FVC, and 75% of the FVC. So from 25% of the FVC, you draw a line up to reach this flow volume curve. So this flow that you have at 25% of the FVC and at 75% of the FVC. So the average flow between 25% of the FVC to 75% of the FVC is called as FEF 25 to 75, which is a reasonably good marker of what happens in the small airways. Okay, so if you want to specifically understand whether there is presence of small airways obstruction, this is a reasonably good one, parameter to tell us about that. So spirometry is essentially measuring two volumes. What are the two volumes? FVC and FEV1. And then two flows. What are the two flows? The peak flow that you get is called as the PFR, and the flow between 25% of the FVC to 75% of the FVC, the average of that flow is called as FEF 25 to 75. And then the ratio between FE1 upon FVC is crucial in determining whether you have presence of obstructive airway disease or not. So essentially, spirometry is only about understanding 5 parameters, nothing more than that. A spirometer measures flow because it has a flow sensor. So a flow sensor is the heart of the machine. And there are different types of flow sensors that are currently used in spirometers. You have the pneumotac flow sensor, the anemometer, the turbine, and the ultrasonic. Out of these, the turbine and the ultrasonic are the most commonly used flow sensors. Pneumotachograph was perhaps one of the oldest flow sensors. Each of these flow sensors has its unique advantage and unique disadvantage over each other. But by and large, all of them are fairly good. And the logic behind which the flow sensor actually measures volume is because the flow is not a straight line. The flow, as you can see, initial portion, the flow suddenly increases, reaches a peak, and then it slowly reduces as you remove all the air out. Because of that, a spirometer actually breaks up these flows into small bits, and then multiplies flow into volume, flow into time, which gives you the volume. And then it adds up all this together in an integrated manner. So that's why a spirometer also requires a computer inside. It needs a calculator inside because it breaks it up into small bits. And then for that microsecond, what was the flow? For the second microsecond, what was the flow? All that is added together to tell you the total volume. Now remember that spirometry is an effort-dependent test. We will do that in the hands-on demonstration later on, where we require good patient cooperation. And the technician has to be well trained, because if the technician doesn't know how to do it correctly, obviously you will not get good quality spirometry reports. A poorly performed spirometry will most certainly give you a wrong diagnosis. And I've seen a lot of wrong diagnosis made because the quality of the spirometry test that was performed was not correct. It is therefore important to ensure, before you do the interpretation, as a doctor, when you get a spirometry report, do not look at the conclusion below. Never rely on the conclusion made by the machine, never. Make your own interpretation. But even before you make your own interpretation, check the quality of the test. And the quality of the test is checked by looking at the volume time and the flow volume loops. The shape of those curves will tell you whether the quality of the test was done properly or not. Never interpret or report a spirometry report without looking at the quality of the graphs. If you do it, half the time you will be wrong, let me tell you that. So quality assurance that includes acceptability and repeatability is a very important component of spirometry interpretation, right? Acceptability has its own criteria, repeatability has its own criteria. What is repeatability? If you perform the test for the second time, if the first time my FVC value was say 3.2, the second time I perform it, I get a value of 3.5. Would I be happy with that? Which one would I use, 3.2 or 3.5? If I use 3.5, maybe the third time the patient would have blown 3.8. So I'm not getting that sense of confidence that this is the real patient's best value. So for that, I have to do minimum 3 maneuvers. And within those 3 maneuvers, the top 2 have to be very close to each other. It is only then that I will believe in myself that this is the best that the patient could have performed, and that the test was repeatable, and therefore I will now go ahead and do the interpretation. So other than acceptability, you have to also look for repeatability, which is very important. Now all these standards for quality check have been reported since 1979. The American Thoracic Society guidelines were the first one that talked about quality assurance. Then 1995, the ATS and the ERS, the American Thoracic Society, and the European Respiratory Society got together and framed standards for spirometry. 2005, they upgraded it, and the latest one is in 2019. So if you want to go through this, please read the ATS ERS 2019 technical standards criteria, because that is the latest guidelines that we have. Now the shape of the curve will actually tell you whether the test was done correctly or not. Now look at this first one. Small mountain followed by a big mountain. What does it tell you? Patient hesitated. What did he do? So he blew out first and then gave a much bigger blow. Now when you look at this over a volume time graph, this is the sort of the hesitation that you get. You get an S-shaped curve. Now if you measure the FEV1 of this patient, this FEV1 will be falsely low because of the hesitation. So you have to make sure that if the patient did a hesitant start, like a small mountain followed by a big mountain, or an S-shaped curve rather than a simple curve like this, then you should reject the test. Otherwise you will get false FEV1 values. Then look at this shape. You can see these serrations over here. Instead of a nice smooth line, there are these cuts over here. This means that the patient coughed during the test. And if the cough is especially during the first 1 second, on the volume time graph, this is how it looks. If it is during the first 1 second, then you'll get a low FEV1. So if the patient coughed, do not accept that test. Here is a patient who did not do a good quality forceful maneuver. He just did, how did he blow? Slowly. So when you do a slow maneuver, you get a dome. When you do a forceful maneuver, you get a triangle. You know, it should be like the beak of a bird. It should be that straight. That indicates a good effort. So good effort is very important. Otherwise, you'll get false low PFR values. Your FEF 25 to 75 percent values also change. Here you can see that the patient had a nice good start, smooth ascent, nice peak over here, smooth descent, but suddenly the flow became zero. Suddenly, all of a sudden. Vertical drop. This vertical drop occurs because of glottic closure or because the tongue is obstructing the mouthpiece. Now, because of that, you lose a portion of FVC. Had the person not done that, he would have removed more air out, so his FVC would have been increased by this much amount. You lost that FVC because of glottic closure. Okay? So the glottic closure looks like this, a sudden horizontal vertical line over here. Perhaps the most common mistake that I've seen in spirometry all over the world is that the patient has not blown for enough time to remove all that air out. For example, in this patient over here, the patient blew only for 2 seconds. Okay? So whatever air that came out at 2 seconds becomes the FVC. Now, if this patient already had obstructive airway disease, his FEV1 value would be low anyways because he's got obstruction. So his FEV1 value is low. His FVC value is low because he blew only for 2 seconds. He did not remove all the air out. So what diagnosis will I make? Low FEV1, low FVC. I will make a diagnosis of restrictive lung disease. So what does the doctors feel? Arey yaar, I was suspecting asthma in my patient. I sent my patient to do spirometry, and the report that I'm getting is restrictive lung disease. I am suspecting obstructive lung disease. Spirometry is telling me restrictive lung disease. How is it possible? Spirometry is not a good test for making a diagnosis of asthma. Doctors don't know this. You know, this is the most common mistake made in spirometry. Patient has not blown enough. Now, what is blown enough? 2015 guidelines said that you have to blow for at least 6 seconds, minimum 6 seconds. The 2019 guidelines now say that if you're suspecting a patient to have severe obstructive airway disease, you have to make the patient blow for at least 12 seconds, 12 to 15 seconds. Because even if you stop at 6 seconds, your FVC still becomes less because these patients with severe obstructive airway disease can blow for up to 15 seconds. So if you make them stop at 6 seconds, the volume of air that they would have removed from 6 seconds to 15 seconds becomes less in your FVC. Then your FE1 upon FVC ratio becomes falsely high. So that is why 15 seconds is now the current norm for how long should the patient perform the test. Obviously, this is in severe obstructive airway disease. In healthy individuals, you'll be able to do that in 2 seconds, 3 seconds. Or if you get a plateau for at least 1 second, 1 second plateau on the volume time graph means it's good enough. All the air has already come out. Okay. So this is the basic principles and technical standards. Now let's go to interpretation. Can somebody tell me the diagnosis very fast? Anybody? Let's see who tells me this fast. Yes, anybody? Oh my God, I thought I would get the answer in 3 seconds here. 4 seconds, it's already been 7 seconds, 8 seconds. Okay, come on, sorry. Anterior wall myocardial infarction. How many of you all made the diagnosis in 5 seconds, 10 seconds? Many of you all did, right? But you all didn't want to speak out. How can you make a diagnosis of a heart attack within 5 seconds when we were actually taught to interpret electrocardiogram using all those parameters? How can you do that in 5 seconds? You cannot, isn't it? But nonetheless, everybody will do it. You just look at it and say, hey, this is acute anterior wall myocardial infarction, ST segment elevation, STEMI, isn't it? A serious diagnosis of a heart attack made in 3 seconds. How confident are you? You are confident, isn't it? Because of the shape of those curves. Now, can you look at the shape of these curves and tell me what is the diagnosis? Just by looking at the shape of the curve. Experts like you can tell what the diagnosis is. Now, I'll teach you how to interpret, first of all, by merely looking at the shape of the curve. Now, before you look at the shape of the curve, this is the fundamental thing that you must check on your spirometry report. The ratio between X and Y axis. In the flow volume, the ratio between X and Y axis should be 0.5 liters to 1 liter per second. Okay? 0.5, half a liter to 1 liter per second should be the scale. And on the volume time graph, 1 second should be equal to 2 liters. Please check this in your report first, because only if you have these scales, then only you should go ahead with the interpretation using the shape. I've seen a lot of spirometry reports giving the wrong shape, the wrong ratios. The wrong ratios give you a funny shape curves. So please check this before you do that. Here is an example. I've seen a lot of these spirometry reports being circulated in our social media. What is the diagnosis? And then you can see over here that the ratios are not correct. The shapes then become abnormal. So how do you interpret spirometry looking at the shape of the curves? So normal volume time graph looks like this. As you can see here, volume of air that you removed in the first 1 second is FEV1. Maximum volume of air that you remove is FVC. By 2 seconds, you have reached a plateau. Now, when this person develops mild obstructive airway disease, this is the shape of the curve. What has happened to the FEV1 value compared to that of a normal healthy individual? Slightly reduced. What has happened to the FVC value compared to that of a normal healthy individual? Same. What is the difference over here? A normal healthy individual has a plateau at around 2 seconds. This person has a plateau at around 4 to 5 seconds. So a low FEV1, slightly low FEV1, and a plateau that is formed at around 4 to 5 seconds is mild obstructive airway disease. As simple as that. When this person develops moderate obstructive airway disease, this is the shape of the curve. FEV1 value has now become much lower. FVC value is the same as that of a normal healthy individual. Is there a plateau that is reached at 6 seconds? No. Low FEV1, normal FVC, but no plateau by 6 seconds is moderate obstructive airway disease. And in severe obstructive airway disease, you can see that the FEV1 value is even low. The FVC value is also low. Why do you get a low FVC value in patients with severe obstructive airway disease? Because when you have severe obstructive airway disease, there is involvement of the small airways. So when you start blowing forcefully, the small airways collapse, and air that is distilled to that in the alveoli remains trapped inside the lung. So that portion of the air doesn't come out. You don't measure that FVC, and therefore you get a low FVC over here. But more important than that, there's no plateau, and the line seems to be going up and up and up forever. So a significantly low FEV1, low FVC, and a line that seems to be going up and up and up forever is severe or very severe obstructive airway disease. Simple. So what are the things that you look for? Is the FEV1 low? Is the FVC low? And is a plateau reached? And if it is reached, when is it reached? So by asking only these 3 questions and looking at this volume time graph, you can make a diagnosis of obstructive airway disease, and you can also determine its severity. As simple as that. Okay? If you think that the volume time graph is simple, the flow volume loop is even simpler than that. You want to know how? So here it is. So this is a normal flow volume loop. So this highest point on the flow y-axis is called peak flow. The maximum volume of air that you remove is called FVC. When this normal healthy individual starts developing mild obstructive airway disease, this is the shape of the curve. What has happened to the FEV1 value compared to that of a normal healthy individual? No change. What has happened to FVC? No change. But there is a concavity over here. The moment you see that scooping or the concavity, that tells you that there is presence of obstructive airway disease. And in the presence of normal peak flow, in the presence of normal FVC, that is mild obstructive airway disease. Okay? When this person develops moderate obstructive airway disease, the only change that happens is the PFR value goes down, FVC remains the same, and the concavity becomes even more. Low peak flow, normal FVC is moderate obstructive airway disease. And in severe obstructive airway disease, this is how the shape of the curve looks like. The peak flow is, the PFR value is significantly low. FVC value is low. Why is the FVC value low? Because of air trapping. But now see the concavity. Instead of a straight line, it becomes a 90-degree curve over here. It looks like the front leg of a dog leg pattern. Very, very classical of severe or very severe obstructive airway disease. Okay, by merely looking at the shape of these curves, you can make a diagnosis of obstructive airway disease and determine its severity. Is FEF 25 to 75 a good parameter to diagnose small airways obstruction? In my opinion, yes. But it comes with two caveats. Never interpret the FEF 25 to 75 until you are satisfied that the patient had put in a good effort. What is a good effort? A nice peak, and the FVC was completed. He blew for a sufficient long period of time to remove all the FVC out. Only then that you look at FEF 25 to 75. The cutoff value for that is less than 65% predicted is equal to indicative of small airways obstruction. Okay. Now this is the shape of a curve that you get in a restrictive lung disease. So this is normal healthy individual, this is restrictive lung disease. What has happened to the PFR value compared to that of a normal healthy individual? Reduced. What has happened to the FVC value? Reduced. But the key point over here is it's a straight line. In pure restrictive lung disease, you will always get a straight line like this. You will not find concavity. If you get a low peak flow, low FVC, and a concavity, then it could be a mixed pattern or it could be severe obstructive airway disease. The concavity is the clue, the clue over here. Even in the volume time graph, FEV1 is low, FVC is low, but there's a plateau at 2 seconds which remains horizontal. When do you find a plateau tells you the diagnosis? As simple as that, whether it is obstructive or whether it is restrictive. Okay. So the algorithm, now I've shown you how to interpret spirometry by looking at the shape of the curves. Now let's do that by following a simple diagnostic algorithm. So if you have to categorize a patient into normal, obstructive, restrictive, or mixed, then you need only two parameters, FEV1 upon FVC ratio and FVC percentage predicted. Now let me take you through this a little slowly. If the ratio between FEV1 upon FVC is more than 70% and the FVC percentage predicted is more than 80, this is normal spirometry. Okay? If the ratio is less than 70%, but the FVC is less than 80%, then earlier we used to call this as suggestive of restrictive lung disease. Okay, now look at what the new terminology says. Out of the suggestive of restrictive lung disease, the true restrictive lung disease are only 40%. The remaining 60% actually fall into this criteria called PRISM. What is PRISM? Preserved ratio impaired spirometry. Ratio is preserved. FEV1 upon FVC ratio is preserved, but FVC is less than 80%. This is called as PRISM. Earlier we used to call them as suggestive of restrictive lung disease, but now it has fallen into this category. If the ratio is less than 70%, it is always obstructive airway disease. If the ratio is less than 70 and the FVC is more than 80%, then it is mild or moderate obstructive airway disease. If the ratio is less than 70 and the FVC is less than 80%, then either it is severe obstructive airway disease or it is a mixed pattern, obstructive and restrictive. Okay. Now the cutoff value to differentiate between healthy and obstructive airway disease, for adults generally it's 70%. For obstructive airway disease we have two components, COPD and we have asthma. For COPD we use 70% for all practical purposes. Okay? For asthma you can increase it up to 75% in an adult. And generally this is what we use. If the pre-bronchodilator ratio is less than 0.7, after giving a bronchodilator it still remains less than 0.7, then that is COPD. If the ratio which was less than 0.7 after giving a bronchodilator becomes more than 0.7, then that could be indicative of asthma. So that is how you differentiate between asthma and COPD based on the post-bronchodilator FEV1 upon FVC ratio. For children, there is no COPD, there is only asthma. So in children, you do not use 75, you use 85% cutoff value. Up to the age of 18, the cutoff value that we use is 85%. Sorry. Once you make a diagnosis of obstructive airway disease on the pre-bronchodilator test, if there is obstructive airway disease, always look for bronchodilator reversibility. Please do that test. 200 to 400 micrograms of salbutamol given with an inhaler in the spacer or a dry powder inhaler or even a nebulizer if you like so, and repeat the spirometry again after about 20 minutes. And if the FEV1 improves by more than 12% and more than 200 ml, that is indicative of good bronchodilator reversibility for adults. And for children, it's only more than 12%. You don't have the fixed 200 ml as well. Even more than 12% improvement is what we use for as good bronchodilator reversibility. Something that has always helped me is if after a bronchodilator administration, the FVC value improves more than the FEV1 value. I am repeating this again. After giving a bronchodilator, the FVC value improves more than the FEV1 value. This is indicative of COPD because of small airways obstruction. So when you open the small airways, the trapped air comes out. And when the trapped air comes out, your FVC value increases. So greater improvement in FVC is indicative of COPD. Okay, so my last slide over here, last couple of slides. Red is pre-bronchodilator, blue is post-bronchodilator. This is the predicted FEV1, predicted FVC. This is the predicted PFR value, predicted FVC, FEF 25, 50, 75. Red is pre-bronchodilator, blue is post-bronchodilator. Now look at this and tell me, is there obstructive airway disease? Yes or no? What severity is it? Mild, moderate or severe? FVC is almost normal, so it is moderate. FVC is almost normal. Is there good bronchodilator reversibility? See the amount of change that has happened in FEV1. Seems to be quite a big change, isn't this? So this is moderate obstructive airway disease with good bronchodilator reversibility. What is it indicative of? Asthma. Let me show you another one. Predicted FEV1, predicted FVC and so on. Is there obstructive airway disease? What is the severity? Severe to very severe. Is there good bronchodilator reversibility? No. So what is the diagnosis? COPD. Okay. I would just like to end by talking something about Z-scores. So earlier we used to express FEV1 and FVC values as percentage predicted. Now the new guidelines suggest that instead of using percentage predicted, we should use the Z-score. What is a Z-score? Any value that is to the left of minus 1.64 is considered to be abnormal. So the Z-score, if it is less than minus 1.64, that is abnormal. That is the cutoff value between normal and abnormal. So instead of talking about percentage predicted, now we talk about Z-scores. So if this is your Z-score, as you can see over here, so if to the left of the Z-score is all abnormal, anything to the left of minus 1.64. So that's one of the new advances that have taken place in spirometry reporting. Perhaps Dr. Chhabra may take that in his case presentation. So I'm going to stop over here, and if there are any questions, I would be more than happy to take. Sorry, ma'am. If no questions, then.
Thank you so much, sir, for illustrating in such a beautiful way and making it so easy to understand again. It was really a feast to listen to you once again, sir. Thank you so much. Can we use the advantage of asking from sir any of the, any doubts, anything is there right now? Dr. Arjun wants to ask.
Sir, can you just explain that FEV1 by FEV6?
FEV6?
Yes, sir.
Okay. So there's something called as a mini spirometer, which was developed by Vitalograph many years ago as an alternative for a standard spirometer because of the size. And they thought that why should you blow for such a long time? Stop at 6 seconds. As it is, the 2005 guidelines, ATS-ERS, had recommended that you have to blow for minimum 6 seconds. So let's blow for only 6 seconds, and whatever value we get with that is what we would use to define presence of obstructive airway disease or not. So earlier we used to use FE1 upon FVC, then the FE1 upon FEV6 came. Why did it come? Because if you were blowing only for up to 6 seconds, then the cost of putting that computational power in that machine became significantly less. And therefore, the cost of the device became very small. So if a traditional spirometer costed 1 lakh rupees, you could get this for about 5,000-6,000 rupees, because at 6 seconds you're stopping. Is that a reliable way of diagnosing obstructive airway disease? Using the 2005 guidelines, yes, they were good, but now that is all changed. 2019, they've said you have to blow up to 15 seconds. Now, we did some work on comparing FE1 upon FEV6 to FE1 upon FVC, and we found that they don't match very well, especially in patients with severe obstructive airway disease. The ratio of FE1 upon FEV6, more than 80%. The cutoff value was 80%, which is equivalent to the 70% of the FE1 upon FVC. So we don't use FE1 upon FEV6 now anymore because it doesn't add any value to your diagnosis. Maybe Dr. Chabra would like to add something to that.
Basically, this was introduced mainly for primary care spirometry, because doing a proper spirometry and getting a full FVC was always difficult, reaching the end of force expiration. So this was a simplification that at least you know that 6 seconds patient is exhaled. But again, it doesn't compare very well with FE1 by FVC, FE1 by FVC. So except for primary care physician, and there's a machine which Dr. Salvi mentioned, which gives only this parameter, but it has never caught on as a useful clinical tool.
I would not recommend use of that in your clinical practice.
Sir, the latest guidelines have asked expiratory time to be prolonged up to 15 seconds.
Yes.
But our experience is in severe disease, if we ask for a forceful maneuver, patient will not be able to do it. So we should ask patient to exhale continuously for longer time. If we ask for FVC maneuver, patient will not be able to prolong the expiration up to 15
You're
seconds.
very right, sir. So now we can do FEV1 upon SVC.
Yes.
You can do that. There's quite a few studies recently have shown that. So you
have to do 2 maneuvers.
have to do 2 maneuvers, yes.
Yes, we have to do 2 maneuvers.
Correct.
Another way is that you can also relax the later part of the expiration. And those papers are also there, that if you relax in the later part of the expiration, that allows you to exhale more. So you get a true measure of vital capacity.
Very true. With the forceful maneuver, the small airways collapse. So then you stop anyways. If you really want to get that, the real vital capacity value, I think a slow vital capacity is what is recommended. No? So thank you very much.
Continuing with the next lecture, I would like to invite Dr. S.K. Chabra sir. Sir is HOD and Senior Consultant, Department of Pulmonary, Sleep, Critical Care Medicine, Primus Super Specialty Hospital, New Delhi. He is a former Director and Professor, Vallabhbhai Patel Chest Institute, Delhi. And sir is a leading asthma researcher with several orations to his credit and more than 150 publications. Thank you, sir.
Blue color. Yeah, I mean PFT. This one? Speaker last one. Okay.
A very good morning, ladies and gentlemen. At the outset, I would like to thank Dr. Nagarjun for giving me an opportunity to be here this morning and talk about a topic which is very close to my heart. Now, listening to Dr. Salvi is always a pleasure. It's just like listening to poetry in spirometry. Makes it things so simple. But he also said that a lot of spirometry is being done wrongly. So it's not as simple as it sounds when you listen to Dr. Salvi. Spirometry is difficult. So picking up from where he left, I'll go on to the clinical applications of spirometry. Now you have a range of lung function tests, and lung function testing begins with spirometry. And in more than 90% of patients, it will stop at spirometry. You will not have to do other lung function tests. Some patients, depending on indications on a case-to-case basis, you have to go forward beyond spirometry. So this is the first lung function, most useful lung function, which we all pulmonologists, internal medicine specialists, and even primary care physicians must understand and know about. So the quality control, again, stressing is extremely important, and that begins right from your purchase of the equipment. You know, you have got low-end spirometers, you have got high-end spirometers, and all of them do not perform equally well. All spirometers, they need to carry a certificate from the manufacturer that these fulfill what are known as the ATS technical specifications. They are equipment performance specifications. Unless these technical features are meeting those, conforming to those, the results are not good. Then the technician requires training, extremely important, because doing spirometry is much different from doing a blood test or even doing an ECG. It's not a passive exercise. The technician has to get involved in the testing. Then the patient has to be coached. If he simply blows out and doesn't do it the way he should, you get wrong results. And then physician, we must know to make sense out of the data, whether the test has been done properly or not. So spirometry is easy, but good spirometry is difficult. Now these are the three areas which Dr. Salvi has already elaborated upon, where we must focus. This is the start of test, peak of test, and end of force expiration. That is how the acceptability criteria are defined. So we should have a good start of test, we should have a good peak and end of force expiration. So we need three such tracings. Okay. Most of the interpretation in spirometry is based on the expiratory part. And it's very important to understand the shape of the loop. The expiratory part is triangular, inspiratory part is half a circle. There are certain situations where the inspiration also gets affected. But most of the interpretation parameters are expiratory. Okay? So FV1, FVC, peak, flow, F25, 75, these are all expiratory parameters. So in interpretation, there are certain key concepts which we need to understand. You measure blood sugar levels. There is a normal range, and that normal range is common to every person on earth. Whether it's a Japanese, Indian, American, you will compare with a fixed normal value. So to understand whether the value is normal or in the abnormal range. But in lung function parameters, there is no fixed normal. All of us in this hall will have a different normal value of a parameter. So that normal needs to be calculated. And that comes from what are known as prediction equations. Prediction equations are developed from population studies on normal subjects. The lung function parameters, for example, let us say FVC, it will vary depending on the race. Caucasians and Indians have different vital capacities. North Indians and South Indians have different vital capacities. Gender, males and females have different vital capacities. It changes with age, it changes with height. So there is no fixed vital capacity. So I can't say that my vital capacity is 4 liters and it's going to stay 4 forever. It will change with time. So all of us have different vital. So we have to have prediction equations. And these prediction equations, they have this format for any parameter, that a constant plus a coefficient into age plus a coefficient into height. So when you start the spirometry menu, the first screen, after asking for temperatures and pressure ambient parameters, it will ask about the patient's age, patient's height, and weight, race. So these are entered for the machine to calculate prediction values, predicted values, because it already has the prediction equations. So it will just put in the age and height and give the calculation of what is the predicted value. Now, there is a drop-down menu in spirometry that will give you a list of several prediction equations. So which one you have to choose is a very, very important exercise. If you pick up an inappropriate equation, that is interpreting a data of an Indian patient using predicted values of a Caucasian, errors are bound to come in. So equations must be appropriate for the local population. The next concept is defining what is abnormal. Dr. Salvi gave a simple scheme of defining abnormality as any value less than a certain percentage of the predicted value, 70% or 80%. Now these rough calculations work fairly well when you don't have appropriate prediction equations. But when prediction equations are there, then the last slide that Dr. Salvi showed, the lower limit of normal, that is the appropriate way. And that is what the guidelines suggest, that you use appropriate equations and then calculate what are known as lower limits of normal. So any value which is less than lower limit of normal is taken as abnormal. 80% rule will work in majority of patients, but towards the extremes of the spectrum of height or age, it will give erroneous values. So the prediction equations, they have a term called standard error of estimate. You multiply that with 1.645. Any value less than that gives you abnormal, right? So 1.645 into standard error of estimate is the lower limit of normal. So values less than lower limit of normal are abnormal. Values on the plus side of the spectrum, 1.645 into standard error of estimate, over and above predicted value, that is the upper limit of normal. Spirometry has no upper limit of normal, right? So it only has a lower limit of normal. So values can be normal or less than normal. For lung volumes and diffusion, however, there are upper limits also. So you can have more than normal diffusion capacity, more than normal lung volumes, but you cannot have more than normal spirometry parameters as abnormal. Finally, the gold criterion for obstruction is specifically for COPD. For asthma, strictly speaking, we don't use it. You have to go by the lower limit of normal, but Gina says that you can use 75% also as a convenient expression. So these concepts have to be understood. And then what about the prediction equations? Till recently, we did not have our own prediction equations. So in around 2014, we published equations for different regions of India, north. So these are equations for North India. And now these are carried by most of the equipments which are available in the market. So in the drop-down list, they would come by this name, Chhabra et al., 2014. So that will give Indian prediction equation. So this gives the format for different parameters, FVC, FE1. So you don't have to actually calculate, just feed in the age, height, and weight, and it will calculate. And the equation also gives a standard error of estimate, so the lower limit of normal can be calculated. If we use equations which are inappropriate, that is Caucasian instead of Indian, then we get wrong values. So this is one paper which we had shown that there is an overestimation of restrictive conditions when we use Caucasian equations. So we must use Indian equations. So this algorithm Dr. Salvi has mentioned, so I'll just skip. But broadly, in spirometry, we identify certain patterns of impairment. We don't make a diagnosis on spirometry. In fact, there's only one disease which is diagnosed on spirometry, and that is, any guesses? That is COPD. Only COPD is defined on the basis of a certain spirometry value, post-bronchodilator values. Okay. Otherwise, spirometry gives you patterns. So normal spirometry, again, normal spirometry means only normal spirometry. It doesn't mean normal lung function. Because there are conditions where spirometry can be normal, but other lung functions are abnormal. Okay. So normal spirometry, generalized obstructive diseases, a pattern of reduced FVC. If we go by the machine interpretation, it will call it as restrictive, but that is a completely unacceptable term. Reduced FVC does not equate to restriction. The definition of restriction in physiological terms is a reduced total lung capacity. So it is only reduced FVC, suggestive of restriction. Restriction is one of the causes of that. There could be other causes. Then you have got certain diseases which reduce FE1 also, which reduce the size of the lung or vital capacity also. Double pathologies, very common in our scenario. So you have got airway diseases, parenchymal diseases. So you get what are known as mixed patterns, that there is a reduced FE1 FVC ratio also and reduced FVC also. Finally, spirometry also gives you clue to certain conditions affecting the central airways, and that is where the inspiratory part of the flow volume loop comes in. Otherwise, for all other interpretations, we look only at the expiratory part. So even the inspiratory part must be done properly. It must be a forced inspiration. Otherwise, if the shape of the inspiration is not correct, then we cannot interpret any abnormality of the larger upper airways. So both inspiration and expiration have to be forced. So these are the different clinical examples of conditions which give obstructive abnormalities, more than asthma and COPD, bronchiectasis, tuberculosis, bronchiolitis, we get obstructive abnormalities. And then restrictive conditions, lung parenchymal diseases, chest wall diseases, pleural diseases. And finally, one must note that it's beyond lung. Even heart failure can give rise to restrictive conditions. So now coming to the cases, can somebody come here? One who is managing. This screen. Okay. So now I'll quickly discuss a few cases. 25-year male, selected as a fireman, underwent a routine medical examination, non-smoker, no history of respiratory disease, no findings on examination, had a pre-employment X-ray which was normal, and spirometry was carried out. So if you look at the values, this is the format in which the report is to be made, and the spirometry software gives you an option of selecting which parameters you wish to report. Some of the machines give you 18 or 20 parameters, but most of these are derived parameters of no value. So the most important parameters on which we base our clinical interpretation, as Dr. Salvi told, are FV1, FVC, the ratio, FEF 2575, and peak expiratory flow rate. So you can delete out other parameters and make a shorter report. So the columns that we get are predicted value. These predicted values, these come from the equation that you have selected. Then next is the lower limit of normal. That again comes from the prediction equation. Then you have got pre-bronchodilator values. If bronchodilator response is checked, then a post-bronchodilator column will also be there. And finally, the percentage change from pre to post. So in this subject, if you look at the ratio, that is the first step, FE1 by FVC. So here the predicted ratio is 83%, and the lower limit of normal of the ratio is 73%. Now we cannot apply the gold criteria here because the patient doesn't have COPD. Okay, so that criteria is only for COPD. So the lower limit of normal of ratio is 73. Here the measured ratio is 78%. So that is a normal ratio. Then you look at FVC. FVC here is observed 5.60. The lower limit of normal is 4.46. Predicted is 5.36. So 5.6 is 104% of the predicted value. So that is normal. So normal ratio, normal FVC, so that is normal spirometry. Okay. The shape of the curve is very, very important. So we saw that the three parts of the loop, the start of the test, peak of the test, and end of the test were perfect. So acceptability criteria was fulfilled. Repeatability, I have showed only one loop, but other loops have to be seen. So you have to have two repeatability, which means that the two measured FEV1s and two measured FVCs should not differ by more than 150 ml. Okay. Then we apply this algorithm. So the sequence of interpretation is first check the quality, have a look at the shape of the curve, acceptability criteria met, repeatability criteria met, then interpretation. The software will always ask, do you want to accept this test or not? Once the patient is done, a prompt comes from the machine. At that time, you can say yes or no. You will say yes when acceptability criteria and repeatability criteria are met. Otherwise, you delete that and go on to a fresh testing. And normally it is recommended that up to 8 times we can make the patient do it, then it becomes too tiring for the patient. This is normal spirometry. Next, a 24-year-old male presented with dyspnea and cough for 4 years, wheezing, seasonal variations, non-smoker, having associated sneezing and rhinorrhea, prolonged expiration on chest examination, eosinophilia of 7%, serum Ig raised to 235, normal blood biochemistries, then spirometry was done. Now if you look at the shape of the curve, there is a concavity, there are two curves. The outer envelope is the post-bronchodilator curve, and even by visual inspection one can make out that the area under the curve post-bronchodilator is bigger than pre-bronchodilator. So after bronchodilator it has improved. Now let us look at the values. The ratio FE by FVC percent, 68%. Now this is the older format of the report as it used to be before this lower limit of normal concept came in after 2019. So at that time we did not have low limit of normal, but 68% is much less than 80% predicted, so it is obstruction. Then FE1 is 2.18, which is 64% of predicted. After bronchodilator, the FE1 increases from 2.18 to 2.83. So that is more than 200 ml increase. Looking at the percentage change, that is 30% increase, so that is more than 12%. Even the vital capacity has improved. The change percentage-wise is 25%, and the value has increased from 3.19 to 4. So much more than 200 ml. So the criteria for bronchodilator responsiveness is met. So this patient, history-wise, is asthma and confirmed on spirometry. So when there is a concavity that suggests airways obstruction, bigger post-bronchodilator loop suggests a good bronchodilator response. Reduced ratio, reduced FE1 confirming obstruction, and a post-bronchodilator response. So our interpretation will be a moderately severe airways obstruction with significant response to bronchodilator. So diagnosis, bronchial asthma based on history and spirometry. A word of caution here, asthma can have a normal lung function when the patient is in remission. So it doesn't mean that a normal lung function rules out asthma. So asthma is a disease which is diagnosed on the basis of history and confirmed on spirometry. If not, on one occasion, we do the test again when the patient is symptomatic and try to document airways obstruction. A 60-year-old male presenting with complaints of increasing dyspnea on exertion, grade 3 MRC, with cough and phlegm, 40 years smoking, hypertensive, normal blood biochemistry, the normal ECG. So if you look at this history with cough, expectoration, a heavy smoker, age 60, so our first impression would be that this patient has COPD. The X-rays are quite compatible with a diagnosis of COPD. There is hyperinflation, and even on the lateral views, the retrosternal space is increased, and kyphosis is there. Hyperlucency is there. So lung function testing in this patient is interesting. If you look at the curves, deep concavity, suggesting a severe airways obstruction. The FE1 by FVC ratio is pre-bronchodilator 32% and post-bronchodilator is 31%. In COPD, the gold guidelines say that you only have to look at the post-bronchodilator values, and the degree of change is not important for diagnosis of COPD. The FVC in this patient increased from 2.18 to 2.82. The FE1 0.69 to 0.88, so that is less than 200 ml. So patient of COPD can show an increase, especially in FVC and sometimes even in FEV1. So that is to say that a bronchodilator response alone does not differentiate always asthma and COPD. So that was a concept that was prevalent a few decades back, that reversible airways obstruction is asthma, irreversible airways obstruction is COPD. That no longer holds now. Patients with asthma may not show good reversibility, and patients of COPD may show good reversibility. It will be very paradoxical if we say that COPD is irreversible and yet the treatment of choice of COPD is bronchodilators. So in this patient, the shape of the loop showed a deep concavity, not much opening of the loop post bronchodilator. The increase in FVC was more than 200 ml. So this patient, we can say, has a very severe airways obstruction with significant volume response to bronchodilator. With history, our final diagnosis is COPD. So this distinction between asthma and COPD while applying spirometry is very important to appreciate and understand. A 25-year-old male with complaints of dyspnea and wheezing, non-smoker, history of road traffic accident, long hospitalization, mechanical ventilation, so had to be tracheostomized. 2 months later decannulated. So 2 months he had to have this tracheostomy. Came with dyspnea to his physician, was given bronchodilators, inhaled steroids, no response, stridor over trachea, chest X-ray not contributory. So a simple spirometry was done, which did not have a display or a printout. Now you look at the values, the FE1 by FVC ratio is 54%, FVC 106% of predicted, so very much normal. FE1 is 69%. So the data would suggest that we are dealing with a patient who has a low FE1 by FVC ratio and FE1 is reduced. So that would sound like an obstructive airways disease. After bronchodilator, there is not much change, 1 and 3%. So there is no response to bronchodilator. But that doesn't solve the problem because the patient is not responding. So in this patient, is it asthma? Is it difficult to treat asthma? So in the absence of a graphic display, it becomes difficult to interpret these kind of cases. Another spirometry was done with a proper graph. And now look at the shape of the curve. Provided the patient has done the test properly, that is the first caveat here, force expiration, force inspiration. Otherwise, you can get any shape of the curve. So that is the first thing. So here we find that the peak is not there. It reaches a plateau, and that's a sustained plateau. Similarly, inspiration is showing a plateau. So it becomes more like a box. So there is flattening both of inspiratory and expiratory part. This is the classical pattern of what is known as a fixed upper airways obstruction. So in a patient who has a history of tracheostomy and dyspnea, obstructive pattern on spirometry, numerical data, graph showing a flattening of both inspiration and expiration, that is indicative of fixed obstruction. And with that history available, this would be a case of tracheal stenosis. So the important learning point here is that there must be a display available with the flow volume loop. So simple spirometers which only give you numerical data on a small screen are not good. They're only screening tools. The ATS gives criteria for what should be the right display size and what should be the right printout. So we should always go in for a machine which has a good display. So visual diagnosis is extremely important. So before you go on to numerical data, always look at the shape. And expiratory limb flattening is always pathological. Otherwise, the normal shape of expiration is a triangle. Inspiration, sometimes if the patient is not doing properly, can get flattened. But expiratory loop is never flat if the patient has done it properly. Finally, all that wheeze is not asthma. So we must look at other causes. So in spirometry, we do get patterns of central and upper airways obstruction, which we suspect from the shape, and this is where the inspiratory part is useful. The obstruction can be variable. That means it changes with inspiration and expiration, or it can be fixed that it doesn't change with inspiration and expiration. So just an example of variable extrathoracic obstruction of different causes. You can have fat deposits, tracheomalacia, paralyzed vocal cords. So here there is a variable extrathoracic obstruction. So the inspiratory loop is flattened in variable extrathoracic obstruction. That is, the flow limitation is on inspiration. Similarly, in variable intrathoracic obstruction, the expiratory loop gets flattened, the inspiratory loop is normal. So shape of the curve, and this is what I shown in the case of fixed obstruction, a box-like loop. Then again moving further, a 73-year-old male presenting with progressive dyspnea on exertion, 1 year, dry cough, non-smoker, Velcro creps and clubbing, Saturation on room air 91%, desaturating on 6-minute walk test. So a CT and complete PFT was ordered. X-ray showing bilateral reticulonodular pattern, and HRCT picture compatible with an interstitial lung disease. The FEV by FVC ratio in this patient observed is 82%. FVC is 37%. So this is the second part of our algorithm, where the ratio is normal, the FVC is reduced. If you look at the shape of the curve, it's a small loop. Looking at the x-axis, about 1.5 liters or so of vital capacity. So quick rise and quick fall. Bronchodilator not producing any significant change. So this is a loop which we say is suggestive of a restrictive pattern. So in this patient, TLC was measured, that came out to be 42%. So that confirmed that this was restriction. Diffusion capacity test was done, which showed it was severely reduced. KCO was reduced 45%. We'll be talking more about what is KCO, what is DLCO in the latter part of today's seminar. So restriction with reduced diffusion capacity, a very, very compatible CT picture confirming that this is a patient with interstitial lung disease. Then a 44-year-old woman with 3 years increasing dyspnea, minimal cough, active cigarette smoker, prominent pulmonary conus, ECG showing prominent P waves in leads to and AVF. Spirometry data in a patient who has got a grade 3 MRC, so substantial impairment in this patient. The FEV/FVC ratio is 70%. FVC is 107% of predicted. FE1 is 91% of predicted. So the values look normal, yet the patient has got substantial dyspnea, and there is no obvious cause on a chest X-ray except that pulmonary conus is prominent. So spirometry can be normal. So in this patient, then you would have to advise further tests. So 90% of the patients require only spirometry. When you don't get an explanation for patient's dyspnea, then we move on to the next level of testing. So this patient had desaturation on exercise, limitation on a 6-minute walk test. The CT scan showed an enlarged pulmonary artery. TLC was 72%. The test that was abnormal was diffusion capacity. The KCO was only 35%. So here is a patient with substantial dyspnea, a normal spirometry, a nearly normal chest X-ray with reduced diffusion capacity, which is very typical of pulmonary hypertension, primary pulmonary hypertension. And this was confirmed on echocardiography. So that is the picture that you get in primary pulmonary hypertension. Talking a bit more about what is known as a pattern suggestive of restriction, where the ratio is normal and FVC is reduced. This is something which is extremely common in the reports that we get, and it has multiple causes for this. One is a physiological variant. When we talk of lower limit of normal, then lower limit of normal statistically is 5th percentile, which means that 5% of normal population we are allowing to be counted as abnormal. That FVC can be less than lower limit of normal in 5% of normal subjects. So that is a normal variation, right? What is average, what is height of a person? Average, normal height. There is nothing as a normal height. There is always a range of a normal height. Okay? So some persons are very short. That is physiological variation. They're not diseased. Then incomplete inhalation. This is the next important cause of reduced vital capacity. And this is one major change which has come in the 2019 guidelines, that in the acceptability criteria, they have also included FIVC measurement. That is, you can only exhale when you have inhaled properly. So when you don't inhale properly, you will not exhale properly, and you will get a reduced FVC. So your inspired vital capacity and expired vital capacity should not differ by more than 100 ml. Only then one is sure that inspiration is done properly. As you will see in the exercises, hands-on training in the afternoon, you have to inhale in first and then exhale. So that inhalation also has to be coached, a complete inhalation. Then faulty equipment, not calibrated, you get all kinds of wrong value. Equipment not meeting ATS standards. Premature termination of the test, that underestimates vital capacity. Use of wrong equations. Rare cases of asthma, sometimes we have this kind of picture. Then PRISM, a new term which has been around since last 8 or 10 years, which now the gold guidelines have incorporated, which I'll talk a little bit more. And then finally, a true restrictive condition. So all patients with reduced vital capacity and normal ratio do not have restriction. Only about half of them have restriction. Otherwise, there are multiple causes of such a picture. Now, let us see quickly how we apply spirometry in different diseases. In asthma, diagnosis and differential diagnosis, yes. But like I told you, asthma can have a normal spirometry when there is remission, when patient is not having symptoms. Then, do we use spirometry to assess control? Gina says that you assess control only on the basis of daytime and nighttime symptoms, use of rescue bronchodilators, and activity limitation. So spirometry is not a tool to check control of asthma as per the guidelines. But when you are using certain questionnaires like ACQ, then spirometry is part of that. Monitoring progress of disease, yes, patients who are declining faster, they are at a greater risk of exacerbations. Do we adjust treatment of asthma on the basis of spirometry? Stepping up, that is based on assessment of control, which is based on assessment of symptoms. So we don't increase treatment on the basis of spirometry results. But stepping down, yes, because objective of asthma treatment is normalization of lung function. So we step down only when the lung function has been achieved in normal range. In acute exacerbations, you cannot do spirometry. There are certain challenge tests which are based on spirometry. So methacholine and exercise challenge tests, you require spirometry. There are a few other issues in asthma. Frequency of testing, how often you require in asthma. There are no fixed recommendations. At diagnosis and start of treatment.
Sir, sorry to interrupt, sir. I think we are exceeding the time.
Yeah, just quickly running through this. So this we can take up in questions and answers. Should bronchodilator responsiveness be assessed on every visit? This is another important question. Is drug withdrawal necessary on each visit? So these questions, which we'll skip for the moment, we'll take up in our exercises. Then the concept of personal best. So these are some of the issues which are there in asthma. Then in COPD, besides making a diagnosis, there are other applications. Then PRISM is a new term which has been coined for preserved ratio with impaired spirometry. Now this does not always mean that the patient is going to go into COPD, but this is one group of patients which require care and follow-up, because some of these patients will turn into obstructive, some of these will turn into restrictive conditions. Then in IPF, we use it for gap index. We use it as a measure of disease progression. In non-IPF ILDs, we use it as a parameter to define progressive pulmonary fibrosis. So to summarize, interpretation of spirometry must be based on review of the shape as well as the clinical data. The machine gives you the option of choosing machine interpretation. It's always advisable not to use that. Always examine clinical data and other investigations. Look at the quality control. Consider the pre-test probability of disease. Select appropriate local equations. Compare with the predicted equations and advise on further testing if clinically indicated. So I'll stop here. Whatever is not covered, or if there are questions, we can have now or later on in the hands-on session. Thank you very much.
Thank you so much, sir, for taking us into this clinical case scenarios and making it how useful spirometry could be. So in the interest of time, we are not taking up the questions, but the experts are available throughout the day, and we should utilize our time to discuss whatever doubts we have with them throughout the day. Thank you so much, sir.
Thank you, speakers and moderators, for this insightful session on spirometry. Now, moving ahead on our second session, which is on oscillometry, I would like to invite the moderators for the session, Dr. Vamsi Krishna Muta, sir. Sir is a consultant pulmonologist at Siddhartha Hospital at Kakinada. I would like to invite Dr. Dayanand, sir. Sir is a civil surgeon specialist at ESI Hospital, Ramachandrapuram, also consultant pulmonologist visiting at Apollo Hospital and Baswatarakam, Indo-American Cancer Institute. I request the moderators to invite the speakers and initiate the session on the oscillometry. Thank you.
Good morning. After a very insightful session on spirometry, now we move on to our next session on oscillometry. Of late, there are so many equipment in the market promoting the oscillometry technique. The know-how, the science behind the performance and interpretation of oscillometry is quite difficult and different from the conventional spirometry, which is we all are well versed with. And when I was going through few review articles of late, very confusing. When to use it clinically, what are the indications, how to interpret, how to inculcate into daily practice. The guidelines are not yet evolved. I think the next few speakers will throw light on this interesting topic. And with this, I'd like to invite Dr. Disha Ghorpade for the first talk on the oscillometry. She is head International Lung Oscillometry Research Network based at Pune. With this brief introduction, we'll hand out the mic to Dr. Disha.
Thank you so much for this very kind introduction, and I feel privileged to be a part of this summit, and thank you so much for the organizers to inviting us from Pune, and wishing you all a very good afternoon, and I bring you greetings. Do is just lay a foundation on the basics of lung oscillometry. The next speakers after me are going to give you a detail on how to interpret lung oscillometry, what do the parameters really mean, what are the correct cutoffs that we need to use. So please pay careful attention to this particular presentation as this will help you understand lung oscillometry in a much more better way. So to begin with, lung volumes. What you see on the screen is a normal tidal breathing, just like what you and me are doing right now. Up and above your normal tidal volume, there's some volume of air that you can still inhale. That is called as your in air that can still exhale below your tidal volume, and that's called as your expiratory reserve volume. There is some volume of air that always remains in the lungs and never comes out. That is called as your residual volume. Your inspiratory reserve volume and your tidal volume together are called as your inspiratory capacity, and your expiratory reserve volume and residual volume together are called as your functional residual capacity, or your FRC. Inspiratory reserve volume, tidal volume, and expiratory reserve volume together is called as your vital capacity, or also VC. And then you have your residual volume. Your vital capacity plus your residual volume together is called as your total lung capacity. The tidal volume that you see, that is the blue shaded portion, is your normal tidal breathing. What your lung oscillometer measures is whilst the patient is doing a normal tidal breathing. Whereas what your spirometer measures is during the phase of inspiratory reserve volume and expiratory reserve volume. So it is a forceful maneuver. Whereas in lung oscillometry, all you need to do is just a normal tidal breathing. We all know that the spirometer is the gold standard to detect obstructive airways disease. However, it comes with multiple challenges. It's an effort-dependent test. Unlike your other tests, like your blood test or your ECG, the patient does not have to put in any efforts. But in spirometry, it's the patient who needs to give a good effort. It has 29 contraindications, 29 indications that you need to take care before performing spirometry. Less sensitive to pick up small airways obstruction, aerosol generating. However, to overcome these challenges, you have the lung oscillometer. Highly sensitive to pick up small airways obstruction, easy to perform because it just requires tidal breathing, can be performed by children, elderly. Recent studies also show that you can use lung oscillometry on with patients on ventilator. And it is predicted to be the future of lung function testing. So to begin with, let me explain to you what is the principle on which your lung oscillometer works. Sir Arthur Dubois, in the year 1976, he was the one who invented the lung oscillometer. He is also the one who also came up with the body plethysmograph. It was in the same year that both these devices were invented. If you carefully look at the cartoon that's presented, look at the upper cartoon. Consider a circuit carrying electric current. When you apply resistance to this circuit carrying electric current, what is going to happen? The output is going to reduce and the pressure is going to increase. Let me explain this to you using an example which you and me do on a daily basis, in our daily lives. Have you watered plants in your garden? If you're watering your plants in a large garden, you're standing at one corner of the garden and the tap is on the other end of the garden. And then you have a long pipe carrying water. You have a good flow, or you have a good output of water at your end. Suddenly, somebody comes and stamps or applies resistance at the middle of the pipe. What is going to happen to the flow at your end? It's going to reduce. And what is going to happen to the pressure at the tap? That's going to increase. If you all have understood this, you all have understood the principle of lung oscillometry. It's as simple as that. Increased resistance, decreased flow, increased pressure. In a normal condition, in a healthy patent lung with patent airways, there is some percentage of resistance. Now what is that? In the large and the medium-sized airways, there is 20% of resistance. In the small airways, there is 7% of resistance. Now there are two types of airflows in the airways. One is your turbulent airflow and second is your laminar airflow. The resistance in your airways depends on the type of flow, the radius of the airways, the gas density, so we have oxygen. Because of the turbulent airflow is in the large and the medium-sized airways, whereas the laminar flow is in your smaller airways. What is lung oscillometry? What do you measure in lung oscillometry? Resistance is all that you measure. Depending on the severity of your resistance, you get a reading in your lung oscillometry report. Consider this animation as a person doing normal tidal breathing. In lung oscillometry, you pass in oscillating pressure waves. These oscillating pressure waves are superimposed on your normal tidal breathing. Depending on the severity of resistance, there is going to be a change in the pressure and there is going to be change in the flow. And that change in the pressure and the flow is measured by the sensor that is placed onto the device. All of this together is called as impedance. A very important term, a very important parameter called impedance. What is impedance? All the resistance that is present in your airways is known as impedance. Now these oscillating pressure waves are formed by two mechanisms. One is either a sound wave is a pressure wave, or second is by an oscillating piston. So depending on the type of device that you'll purchase from the market, you are going to have different mechanisms in which these pressure waves are generated or developed. Now before I go ahead, I would like to explain a very unique property of sound. This will help you understand oscillometry in a much simplified manner. Remember, sound is a pressure wave and it is used in lung oscillometry. Have you heard this? Do we listen to Man Ki Baat? Do we listen to our Prime Minister? Now our Prime Minister is sitting in Delhi. However, you can still listen to the content that he's speaking in Hyderabad, right? The same content. Even I'm able, when I'm in Pune, I can still listen to the same content at the same given point of time. In comparison versus the radio mirchi. Do you all have the radio mirchi in Hyderabad? Yes. So the jockeys, even we have it in Pune, but the radio jockeys, the songs that are being played are very different at this given point of time. Why is that? It's because of the frequency. Now the radio, the All India radio that you're listening to, the All India radio, the entire nation can listen to the same content at the same given point of time, is because of the frequency. The All India radio uses a smaller frequency, whereas the Radio Mirchi 98.3 FM uses a higher frequency. Therefore, you cannot listen to the same content that is being played in Maharashtra versus what is being played in Hyderabad. Now listen to this very important property of sound. Sound waves of lower frequency, the All India radio uses lower frequency, travels longer distance, whereas sound waves of a higher frequency, the Radio Mirchi, travels shorter distance. Let me give you another interesting example. Do we have music lovers in this auditorium? Yes. Have you listened to these notes? Sa re ga ma pa dha ni sa. Yes? So I went on to Google and I checked the frequency of these sound notes. Say for example, you're sitting in an auditorium and listening to classical music. I looked up at the frequencies of these sound notes. What I found out was Sa had a frequency of 256 Hertz, a shorter frequency, whereas Ni had a higher frequency. So I want to know from y'all, if you are sitting on the last bench of the auditorium listening to these classical notes, which is the sound note that you will be able to hear clearly? Sa. Why? Because it is of a lesser frequency. Now let's apply this unique property of sound in lung oscillometry. Your airways starting from the first generation to the 23rd generation. From the 1st to the 7th generation are your large airways. From the 8th to the 23rd generation are your small airways. In lung oscillometry, sound waves are passed into the airways. Now if I want to measure resistance in the large airways, I'm going to send in a sound frequency which is lesser. That is, I'm going to pass in 20 hertz. Why? Because I don't want it to travel right up to the small airways. But if I want to measure resistance in the total airways, I'm going to pass in a lesser sound frequency or pressure wave. Say I pass a 5 hertz frequency. Now I know resistance in the large airways, I send in a higher frequency. Can I call it R20? So if I want to know resistance in the large airways, I have R20. If I want to know resistance in the total airways, I'm going to call it R5 because I'm passing in a shorter frequency. If I want to know resistance in the small airways, can I say R5 minus R20? Yes? So now I know using lung oscillometry how to measure resistance in my large airways, in the total airways, and in my small airways. And I call it R5, R20, R5 minus R20. Simple enough? Why not less than 5 hertz? So in lung oscillometry, you use a range of frequencies ranging from 5 hertz up to 30 hertz. We don't use less than 5 hertz because when we are passing in pressure waves, they may get disseminated or they may get lost in the process of reaching up to the small airways. Why not more than 30 hertz? Is because it causes discomfort to the patients. So you use frequencies ranging between 5 to 30 hertz. This again depends on the kind of device that you are using. So these are your oscillatory pressure waves being passed into the respiratory system. These oscillatory pressure waves are of 3 types. One is your single frequency. Like I mentioned, you have frequencies that are passed into the respiratory system. In single frequency, you have 5 hertz, followed by 10 hertz, then 15 hertz and 20 hertz. So it is one after the other. That is called as your single frequency or your mono frequency. There is a second type called the impulse oscillometer. What is impulse oscillometer? In these, all the sound waves, all the frequencies are clubbed together and then they are pushed into the respiratory system as an impulse. So it is 5 plus 10 plus 15 plus 20 as a combination is passed into the respiratory system. There is a third type called the pseudo-random noise. Randomly, any frequency is passed into the respiratory system to measure the resistance. So these are the different kinds of frequencies. These are the different kinds of devices that you will find in the market. So just to explain it in more detail, look at the monofrequency and the impulse. Impulse is a combination of all the frequencies. What is the difference between monofrequency and impulses? So the device that you see on top is the Antlia device, which you will also be doing in your hands-on session. That is a monofrequency. That is, frequencies one after the other are pushed in on your, or superimposed on your normal tidal breathing. In impulse, it is a combination. In a monofrequency, it's a gentler impulse because you're passing one frequency at a time. In an impulse, you're sending it all together. Therefore, it may cause a slight discomfort to the patient. Cost-wise, the monofrequency is cheaper in comparison to the impulse. Monofrequency will take slightly longer, a few seconds longer than the impulse to complete the test. This is a very important slide as it summarizes all the parameters that you measure in lung oscillometry. First is the resistance denoted as capital R, like I've mentioned to you before, resistance in the large airways and resistance in the peripheral airways. Now there's another very important parameter called as reactance. Reactance is denoted as capital X. It is a combination of something called as inertance and capacitance. Inertance is denoted as capital I. Capacitance is denoted as capital C. Now, what is reactance, what is resistance? Let's understand that. Resistance. The blinking arrows that you see over here are the resistance that are being applied. So you have resistance offered by the walls of the airways, the parenchymal tissues, the chest wall. So we know about resistance denoted as capital R. It is known as respiratory resistance. Taking you all back to this particular slide, what I want to highlight here is the functional residual capacity, or the FRC. FRC is that volume of air that remains in the lungs. Keep this in mind. What is reactance? Reactance is a combination of inertance plus capacitance. What is inertance? FRC, the air that always remains in your airways. Now this air that is present in the airways, when you're passing in pressure waves or when you're breathing, there is some resistance that is applied by the air that is already present in the airways. That resistance is called as your inertance. What is capacitance? Capacitance is the elastic property of the alveoli. Remember, capacitance is dominated in the small airways. The property to extend and come back to its original position is called as capacitance. Capacitance again is a combination of compliance and elastance. What is compliance? Compliance is the ability to stretch, and elastance is to come back to its original position. Remember, in COPD, the compliance increases, elastance reduces. In ILD, your elastance increases and compliance reduces. Just to take you all through the basics of interpretation, what you see over here is a graph divided into two parts. The upper part is resistance and the lower part is reactance. This line that you see is the line of resistance. Now remember, this is a graph of a normal healthy individual. This line that you see is the line of reactance. Remember these two parameters in lung oscillometry, resistance and reactance. Resistance denoted as capital R, reactance denoted as capital X. On the x-axis, what you see is frequency of pressure waves increasing, that is 5, 10, 15, 20, 25. On your y-axis, you have resistance and reactance. Resistance is positive, reactance is negative. What you observe over here is the line of resistance is constant, even with the increasing in the frequency of oscillations. So can I make this statement that resistance is frequency independent? In a normal healthy individual, resistance will remain constant even with increasing frequencies. But the line of reactance will move from the region of negative to the region of positive. So if you look at the graph, this line of reactance is moving from negative portion to the positive portion. So the reactance is frequency dependent. Two very important parameters again. One is your resonant frequency, or your FRES, capital F and RES. What is FRES? The point where the line of reactance intersects and moves from the negative to the positive is called as your FRES. And because of this intersection, there is a triangular area that is formed. And that area is called as your Goldman's triangle, denoted as capital AX. The importance of FRES, the importance of AX, you will understand during the talk of interpretation. But as of now, just keep these two concepts in mind. These are the graphs of mild, moderate, severe, talking about what happens in resistance and what happens in reactance. Just to give you all an idea, if you look at these three lines, for mild, moderate and severe, what is happening? Resistance at 5 Hz is increasing in case of mild, moderate and severe, whereas the line of a normal, resistance at 5 Hz is less. It's not increased or elevated. What happens in your reactance line? Remember, the line of reactance moves from the negative to the positive zone. So when that is happening, in case of mild, moderate and severe, this FRS or this point of intersection moves towards the right. In case of a normal condition, it's more towards the left. If you observe the line of severe, this point of intersection has moved considerably towards the right. Because it has moved towards the right, your FRS is going to increase and your triangle, the area of the triangle is also going to increase. So your AX and your FRS will increase in case of mild, moderate and severe obstruction. Your R5, that is resistance at 5 Hertz, resistance in the total airways is also going to increase. So to summarize all up, these are the different parameters that your lung oscillometer report must have. R5, R20, R5 minus R20. You should have FRS, that is resonant frequency. Just like resistance, you should also have reactance, denoted as capital X. So you need to have X5, X20, X5 minus X20. There are new parameters such as reactance during inspiration, reactance during expiration, difference between the inspiration and expiration reactance. So all these areas still need to be studied. However, you will know much more in detail in Dr. Salvi's talk, the importance of all these parameters. These are all the applications of lung oscillometry that various literatures have suggested. Different areas that it can be used. However, all these areas still need a lot of study and research. Moving ahead, how to perform lung oscillometry. It's a very simple technique to perform, a very simple test to perform. But having said that, there are some people who find it difficult to do this test, is because there are vibrations that are pushed in. These vibrations are not too harsh, but some people still find it difficult. Majority of them find it easy to get this test done. So I advise all of you all, during the hands-on session, you all go ahead and do this test on your own and experience how you feel when you all get this test done. The person doing the test needs to do normal tidal breathing, seated in an upright posture. Sitting position is very important. It should be an upright position. A nose clip is very important. A very important step in this particular test is you need to ask the patient to hold his or her hand against the cheek. Why? It's because when we are passing in pressure waves, we don't want the other sounds to get mixed with this pressure wave that we are passing in. So very important to hold the hand against the cheek when the patient is getting the test done. In case of children, you can ask the technician to stand behind, or you can ask the parent of the child to stand behind and hold the child's cheek from behind. Just like your spirometry, you need to do 3 pre-tests and 3 post-tests. Tidal breathing for at least 30 to 40 seconds, depending on what kind of a device you all are using. Steps while getting this test done. First is explain to the patient why this test is being done, how this test needs to be done. Second is demonstrate. Use a mouthpiece and demonstrate it to the patient, even if it involves normal tidal breathing. Head and body posture. Visually, you need to examine. Visually, you need to observe a lot of things. Because please keep in mind that like your spirometry report, you do not get the quality of the graphs in your lung oscillometry report. So it's very important for you all to observe whether if the patient is getting the test done correctly or not. Because after you get the report in your hand, you're not going to have a chance to find out whether it's a good quality test or a poorly done test. And start the test. In a mono frequency, the frequencies increase. So 5 Hertz is a gentler impulse. 12 Hertz is slightly more harsh, followed by 20 Hertz. So when these frequencies change, the patients feel the vibrations increasing. So at certain times, it may happen that the patient may feel a little uncomfortable and stop the test. So it's very important to explain this one step to your patients, that the frequencies are going to increase, but not to worry, you continue your tidal breathing. Now, there is one way in which you can identify or just get an idea whether the test that is being done, that you have received in front of you for making a diagnosis, whether it's a good quality test or a poorly done test. There is something called as covariance. Previously, the guidelines used to talk about something called as coherence, COH. Now we do not use COH, we use COV. What is covariance? Covariance will tell you what is the variation between the trials, the 3 trials that you have done in pre and that you've done in post. So in adults, the covariance value, you get it in the form of percentage. So your COV in adults should be less than or equal to 10%. Anything more than 10% gives you a hint, gives you a clue that there could be some artifacts whilst the test was being done. And by artifacts, I mean the person must have coughed, the person must have, instead of exhaling out, has inhaled, the person may have stopped breathing, there could have been an air leak. So all these artifacts could have been taken place, therefore the COV value is more than 10% in adults. In children, it is 15%, so it should be less than equal to 15%. I don't know if you all are able to see clearly the values, but what I've highlighted is R5, this is R5. The COV value here is 13.54 for R5. So it is more than 10%. These are the results of an adult. It is slightly more than 10%. The Z5, here is your Z5. The COV value is 12.54. So again, slightly higher than 10%. You will get COV value only for R5 and for Z5 in your report. These are the standards, suggested standards by the ERS. They have suggested that you have all the parameters that I've mentioned put up there should be in your report. You need to have a section for the technician's comments or the person who's got the test done. Why? Because in case of any artifacts or in case the patient was unable to do the test, it's the technician or the person who's getting the test done, his or her responsibility to mention this in the comment section. So it becomes helpful for the doctors to make the right diagnosis. So this is just suggested by the ERS technical standards. So this was all about lung oscillometry. I will take the next 5 minutes and just introduce you all to what we are doing at our center in Pune called the ARISE network. This is the International Network for Lung Oscillometry Research. It has been initiated very recently, that is in the year 2021. In fact, even Dr. Nagarjuna is a part of this particular network and is contributing very actively. Why did we start this initiative? With a very clear vision to do good quality research in the field of lung oscillometry, to do training and advocacy through passion, innovation, and collaboration. How do we function? We act as a data coordinating center, not only for the operations, but also for the science. We help all the doctors who have access to this device to develop good quality research questions and answer these research questions through a very correct methodology. And how do we do that? Is we have a very good team in Pune. We have a very good statistics team as well, who helps us bring meaning to the data that the doctors contribute. As of now, we have 27 doctors who are part of the network, who are contributing very actively to the network. This is a spread across the country. We have 5 pediatricians. We also have an international collaboration. And through all this, we've started our first study is to derive the cutoff values for the Indian device Antlia. So this is an Indian-based company based in Bangalore. They have developed a monofrequency device, and they are still working on it. It's still the software is progressing. So for this particular device, we are deriving a cutoff value. Our Indian population requires a different cutoff value. We cannot use the cutoff values that are used for the Western population. So that's what we are doing. We are collecting, it's a registry called the LEAD study. We collect all the information related to lung oscillometry in this particular registry. And on the basis of that, now we have, this is an old number, but now we've crossed 6,000 data for the Indian population, and very soon we will come up with our own cutoff values for the Indian population. We had 2 papers this year on lung oscillometry to differentiate between healthy subjects and those with obstructive airways disease, what is the right cutoff. And we also had lung oscillometry parameters compared between healthy as well as post-COVID patients. Both were presented at NAPCON. So this is the progress through the ARISE network. Who can become a member of this network? All those who are very passionate about finding answers to lung oscillometry research questions. Second, who have access to the lung oscillometer. We are also collecting data for the impulse oscillometer. And third, we need to sign an agreement. There's an MOU that we signed between your institute and our institute in Pune. We have a website called the Lung Oscillometry website, the ARISE website. So you can log in. It's www.lungoscillometry.com. So I invite any of you all who would love to be a part of this network, please do get in touch with me. We would love to work together and find out answers to a lot of questions that still need to be answered in the field of lung oscillometry. So thank you very much. Thank you for your patient listening.
Thank you, Dr. Disha, for elaborately explaining the principles of physics behind this complex study. Your animations were excellent and made the life of pulmonologists much easier and understanding the complex physics. And also we hope that your research throw light into as you said, there are more questions than answers. And the exact place of the oscillometry in clinical practice is evolving. I hope your research brings out the answers for them, particularly to our Indian population. With this, I would like to invite the next speaker.
Yeah, I invite Dr. Atri Gangaupadhyaya, a passionate pulmonologist from Ranchi. The pitch is ready. Now, Atri will enlighten us. Over to you, Atri.
Screen is visible. So thank you for the kind introduction, and we started with poetry. From there we went to eloquence, and now after physics I am a physician standing in front of you. I bring greetings all the way from Ranchi, Jharkhand, where recently a part That's better. So what I am going to talk about is performing oscillometry, iOS and FOT technical standards, when to perform oscillometry, advantage over spirometry, and will oscillometry ever replace spirometry? A very famous Hindi Bollywood movie, Golmaal, there the hero told that to explain Kabir needs a lifetime, but I will try in the next 20 minutes. So I request the moderator to rudely interrupt me at 20 minutes in the interest of the other speakers also. The discussion can continue during our demonstrations or after that also. I want to thank Dr. Nagarjuna and entire Yashoda team for the opportunity. I thank my patients for trusting me with this oscillometry in our state. And I thank Madam Disha here, who was kind enough to take my first one-on-one training on oscillometry, and Salvi sir, who orchestrated the same. This scenario is faced by all of us. 70-year gentleman comes with breathing difficulty on effort, dry cough, both are gradually progressive. He is a current smoker, 25 pack year exposure, initial cardiovascular examination and echo is normal. What should be my investigation of choice to confirm a diagnosis? We are all looking at possibly a COPD, and COPD as per all the guidelines is defined by spirometry. So we all did a PFT or spirometry. Despite good demonstration, he is unable to give an acceptable, valid spirometry even after 8 attempts. So too many failed attempts? Can we try another way? Second scenario, again faced by all of us. Mentally retarded 15-year boy suffering from recurrent seasonal cough. Again, cardiology exam echo normal. Mentally retarded? So will this person understand the instruction? Possibly no. The answer to both of this is oscillometry. Now, when I acquired this new device, because I am a private practitioner, I have a clinic. How do you convince a new technique to patients? I need to explain something which the patients can catch on. So I started telling the people that oscillometry is the sonar of the lungs. Just like a submarine or a ship uses depth finding technology by the principle of echo of sound waves, maybe oscillometry is going inside your lungs. So I tell the patient that there is a new test which is the sonar of the lungs which you must do. What do I measure? R stands for resistance of the airways, which Disha ma'am told very well. 5 hertz total airway, 20 hertz is what? 5 to 20 hertz is what? X stands for reactance, that is parenchyma plus smaller airways. FRS stands for resonating frequency. This is measured by that machine. Requisites for the test, it is the same for iOS or FOT, whichever machine, since we are measuring the same thing. Since we are using sound waves, I would want the room to be as quiet as possible. Someone speaking in the room, a mobile phone ringing in the room can also theoretically cause unnecessary sound which can superimpose with the sound generated by the machine. So quiet room. It should not be an open room. Closed room, preferably no air currents. Comfortable ambient temperature. Particulate matter plays havoc in these pressure waves. So take care of air pollution. If you are working at a pollution prone city, use some air filters in that room. FOT diagram. The machine is held by a performer. The nose clips are occluded. The cheek needs to be compressed. Why the cheek needs to be compressed? Salvi sir showed some very beautiful diagram of straws or pipes. So consider our airway as a single trumpet or pipe. It should be dispensable only by the air wave or sound wave. But if the cheek is moving, that causes an artifact which can actually dampen whatever resistance was supposed to be measured. So the cheek must be firmly pressed. If the child cannot, then some adult should do it. iOS, it is a larger machine and a fixed machine. So it's like a C arm carrying the machine. So here, no one needs to hold the machine. It is a fixed machine. Just the patient is sitting comfortably and the nose clips are there. Patient is holding the cheek and doing the tidal maneuver in the machine. Sit comfortable. If you are not comfortable sitting, there will be some movement at the neck, and that movement at the neck can also be a confounding factor. So sit comfortable, nose clipped, cheeks compressed, mouth interface in, tidal breathing. 20 seconds for a reading. For FOT, it can take up till 40 seconds. 3 readings, best selected by the computer. Reversibility is same as for spirometry, not anything else. The technician just presses the start and stop buttons and checks your performance. Patient effort is immaterial here. Now, if the child is unable to understand tidal breathing, because since I had the only machine in the state, lot of children or pediatricians refer some children to me for this test. Children is unable to understand tidal breathing, ask them to count numbers, say a rhyme, or if nothing else, allow the child to cry. Even that is sufficient. Yeah, children cannot be able to sit. Children love to fidget. So in that case, mother's lap is also a good idea. But that can be done some modification for children. A genuine problem. This gentleman won India the Cricket World Cup. After the World Cup, it came to be known that he had a tumor in his lungs. And before every match, pre-fitness, there used to be a spirometry, which he used to perform wonderfully. That's why he was allowed to play in every match. So what if my spirometry is normal, but I'm having symptoms like a lung tumor? The other way is also right. What if my spirometry is abnormal and I'm not having any symptoms? So maybe this is why we are looking at tests beyond spirometry, not only oscillometry, but all the tests that we will see today or tomorrow. Myth. People unable for spirometry are the only indication for oscillometry. Even when I was considering purchasing an oscillometer, when I was, let's say, reading through articles or talking to people, many people told me, or some articles were there, that the research was on people who were unable to perform a spirometry. But as I started using the machine, as I became one with the machine, as I started understanding the machine, I realized that if you learn oscillometry, it can actually become your first line PFT. Like coronary artery disease, echo, ECG, lipid markers, stress, TMT. Ultimately, you need that coronary angiography. Without coronary angiography, there cannot be CAD. So, there is a genuine potential that if you understand oscillometry, it will become your first line PFT. Various clinical scenarios where I am using the machine. Patient unable for spirometry. In asthma, to demonstrate reversibility, sometimes the patient history symptom is asthmatic, but a very good spirometry is unable to demonstrate reversibility. And there is a very famous saying that all that wheezes may not be asthma. So clinical features is there. Your spirometry is not getting reversibility. Will you stamp it and treat it as asthma, or would you want to do something else? COPD, to demonstrate obstruction where the patient is unable. Bronchiolitis, drug-induced lung disease. Cancer survival has increased. In my own biological family, there are 2 cancer survivors. I'm very thankful to the oncologists. But these people get lots of drug-induced lung disease. It may be due to the chemotherapy agents, it may be due to the radiation, it may be due to immunotherapy agents or whatnot. Rheumatology patient with chest symptoms. Thanks to wonderful diagnostics, serum diagnostics, rheumatology patients are getting diagnosed earlier, treated wonderfully, but these people have chest symptoms. Earlier, their rheumatology diagnosis was delayed. They used to die of kidney failure, myocarditis. Now that these people are surviving, they go on to chest symptoms. Also, sometimes chest symptom can be the first part of a rheumatology diagnosis. When we are standing in 2023, a very important umbrella has come up post-COVID chest symptomatics who have a normal spirometry, who may have a inconclusive radiology, and follow-up of a diagnosed ILD without radiation exposure. These are genuine scenarios where oscillometry can be important. I believe that oscillometry is going to replace spirometry soon. All these people can get replaced anytime because cricket is a very competitive game. If you are unable to perform for 3 to 5 matches, you may be replaced, and there are 100 crore plus Indians who can take your place. Currently, pulmonologists are most talked about after the worst pandemic in human history. I consider COVID was an extinction threat. The next decade in medical science, I proudly say, will be ruled by pulmonologists, and innovation will first focus on pulmonary medicine. May it be investigation, may it be pharma, may it be good hospitals. Obviously, we will have to rethink our traditional practice and innovate ourselves. Existing diseases may need to be redefined and re-diagnosed by newer and better modalities for better treatment. Isolated disease will be replaced by disease syndromes with considerable overlaps. We have all heard of asthma COPD overlap, sleep apnea COPD overlap. I talk to you about obstructive airway disease, tuberculosis overlap, obstructive airway disease, air pollution overlap, obstructive airway disease, occupational lung disease overlap, obstructive airway disease, post-COVID overlap. So many overlaps we are looking into. So it's not an isolated disease, more of disease syndromes. Certain points where already the oscillometry is scoring better than spirometry. Age independence, intelligence independence, technique independence. The oldest patient I had done was 92 years. The youngest patient I had done was 2 years. Even the book or the manual tells that 2 years above you can do a oscillometry. So this is what I have done. Demonstration of reversibility. I was telling that sometimes in asthma, oscillometry is a better tool for demonstration of reversibility. Airway narrowing is proportional to volume or radius to the power 3. Airway resistance inversely proportional to R power 4 for laminar flow. For turbulent flow, it can become R power 5. Thus, reversibility is better appreciated on oscillometry because the power is more over here. And this solves the dilemma of poor reversibility in many patients of spirometry. Otherwise, what would be the other way out? Symptoms of asthma, spirometry does not show reversibility. Then we may have to do a bronchoscopy to look at the upper airways, look at the trachea. But here oscillometry can give a reversibility and may save the patient from an unnecessary bronchoscopy. Aerosol generation in the post-COVID era. It is lesser with oscillometry due to tidal breathing. After COVID, behavior of people have changed. People are afraid to cough. People are afraid to go out when they are coughing, and masks in public places. So, wherever there is an aerosol generation, induce sputum, that is something probably it is now being discouraged, that no, rather than induce sputum, go for a BAL. Similarly, aerosol generation is lesser with oscillometry due to the tidal breathing. Spurious bronchoconstriction does occur sometimes in COPD, elderly people, sometimes very young people, and in the severe obstruction due to that maximum inspiratory maneuver. So that is somewhere oscillometry can score better. Due to penetration to deeper and smaller airways by those beautiful sound waves, oscillometry will give earlier abnormal report compared to spirometry. My friends, childhood friends, school friends come to me that I am a smoker. I want to know whether my lungs are being affected or not. Often, if that person is asymptomatic or athletic, the spirometry can come normal. But sometimes oscillometry can give an earlier warning, not only for smoker, occupational lung disease. The state where I work at Jharkhand, it has lots of mines, coal mines, iron mines, uranium mines. Now these mines, people who work in the mines and people who live in those areas, because there are certain open mines also, they can have lots of smaller airway problem, which needs to be catch hold of earlier to help them. Once it comes to symptomatic, it becomes irreversible. So there oscillometry can give us a window. Redefining a disease and guiding treatment. Almost every 2 to 3 guidelines, the COPD definition undergoes a change. Earlier, Gold had labeled COPD irreversible. Nowadays, such beautiful terms like heterogeneous, treatable. Spirometry had given concept of fixed airflow limitation in COPD. As we explore more and more oscillometry in COPD, now this is a wishful thinking or an optimistic thinking that maybe this concept of fixed airflow limitation may also be discarded. That in the PRISM group or pre-COPD group, maybe something else can occur. My most famous film of all time, every weekend I try to watch one of the Lord of the Rings, one ring to rule them all. Similarly, oscillometry is theoretically one test for various pathologies. Obstruction also, restriction also, small airways also. Just like one ring to rule them all, one test to diagnose them all. Some increasingly common diseases where oscillometry may be the diagnostic answer. Air pollution related lung diseases. In my city, I am picking up asthma in children without family history, very common. It may be due to air pollution because Ranchi is a new capital. It is still expanding, lots of cars, lots of new buildings. So air pollution is there. Rarer forms of occupational lung exposure, drug-induced lung disease, transplant patients. We all agree that transplant patients are surviving good lives, near normal lives. These people tend to get lots of that graft versus host immune disease that manifests as bronchiolitis and early lung involvement in rheumatology. These situations, oscillometry may be the diagnostic answer. 95, there was a study. 2004, good study. 2007, wonderful study. Then why even in 2023 are we debating? Because in 2020, we were forced to stop doing spirometry because of something very catastrophic, something very unfortunate. 2020, iOS, reasonable option to monitor lung functions in the era of COVID-19 pandemic. So when we were stopped to do spirometry, maybe we had started worrying that there was another technique. Go back to the literature. Let us start trying to do this. So research was accumulating from the 1990s, but there was no push until maybe spirometry had to be stopped. And now that the world is opening up after COVID, maybe oscillometry will also open up to the world. Now, everything is not rosy. Let me criticize against oscillometry. Fitness for surgery. We need lung volume to assess fitness for surgery, spirometry. But again consider my argument. Whether the pre-op patient who needs a fitness certificate be able to perform this spirometry accurately or not. We have a fracture of neck of the femur, hip fracture. Will this patient be able to sit upright to perform a spirometry? I shall not lay claim that oscillometry is a replacement for spirometry in fitness for surgery cases, but we may need to look beyond spirometry if such patients unable to perform the spirometry, or a huge ascites, abdominal tumor with ascites patient will never be able to perform a very valuable spirometry. Second biggest argument, definitely cost. In Indian market, the cost of acquiring remains very high and every practitioner might not be able to afford it. Same for cost of the test. It can be much costlier than a spirometry. So every patient who afforded a spirometry, let's say someone goes to the doctor every month or every 3 months, gets a spirometry done. If I start telling this patient that you come to me every month or every 3 months and get an oscillometry done, which would be costlier, the patient may not be able to afford it. So currently what my practice is, at diagnosis, I do an oscillometry. If I'm unable to understand, I add an spirometry to that. For follow-up, monthly, I do a spirometry. Quarterly, I do an oscillometry. If the patient deteriorates despite good medicine, I do an oscillometry and follow-up. That is my practice currently. To sum up, pulmonary medicine is an independent subject with maybe fastest growth. Pulmonary function testing is an integral part of pulmonary diagnostics. Never be a pulmonologist without good pulmonary diagnostics, please. The finer my diagnostics is, the better will my diagnosis and patient's outcome. Every better patient of a chronic disease diagnosed early and accurately will be a new advocate for better pulmonary medicine facilities. So many hospitals market lung transplant. Who is the best advocate of a lung transplant? The person who survived a lung transplant. Similarly, we are looking at chronic diseases, asthma, COPD, bronchiectasis, bronchiolitis, ILD. If you diagnose this patient early and accurately, you can give a reasonable quality of life, and that patient will be your advocate for better pulmonary medicine. I would want to dedicate everything to this great gentleman, without whom this program would not have been possible. At the end, I want to tell this, wherever I go, I try to give this slide, Indian theory of relativity. Albert Einstein, the great scientist, gave the theory of relativity that everything in physics or matter is related. Time is related to mass, mass is related to distance, whatever. The Indian theory of relativity was given by some great Indian politicians whose name I would never utter, that relative is everything. That my son will become the chief minister, my nephew will become the prime minister, so on. Similarly, in this Bhagavad Gita famous picture, what was yours tomorrow will be mine today, will be someone else tomorrow. So similarly, in medical science, everything is relative, or relative is everything. A test that was unheard of yesterday, we are debating whether it will replace spirometry today. Tomorrow maybe something else will come and we will forget oscillometry. So the purpose of this conferences should be that if we are practicing physicians, we are all scientists. We should always have that open mind that nothing is definite, relative is everything. I want to thank all of you for your patience. You can note down my number and we can take some questions. I think I finished in less than 20 minutes.
Thank you, Dr. Atri, for bringing us from principles of physics to clinical practice, from bench to bedside. Apparently opened a Pandora's box in lung function test, spirometry versus oscillometry. But I believe the research where the clinical decisions are based on oscillometry are yet to be out. The guidelines are still evolving. We'd like to have a few questions from the audience.
Dr. Atri, it was a wonderful lecture. And from what I understand also, what I've seen in the last 6 months is there are several centers who are now purchasing oscillometry and are using it on a day-to-day practice. I think Dr. Disha also would agree with me that the number of investigators in her network are also increasing as the months go on. So this is a question both for you, Dr. Disha and Dr. Salvi, now with availability of 3-4 machines, the iOS, the Antley, or the Schiller FOT. So if at all a person is wanting to purchase or start oscillometry, so which one would you suggest?
Dr. Salvi has a slide on that basically in his talk.
Okay.
Maybe that question will be answered by that slide.
And I would request the audience also to be more open and ask questions, because the more you ask, the more you learn. That is what I always say.
Now, I run a self-help teach yourself oscillometry group. Since it is not in the textbook, anyone who acquires a machine, I try to add them on a WhatsApp group, and we ourselves share cases with scenarios, and we try to help each other. I can see many people from my group also over here, so very happy to see you here. And so definitely, if you have a machine, oscillometry, if you are doing oscillometry regularly, please reach out to me. I will definitely add you to that group. It's just a WhatsApp group, no registration, no MOU, no agreements, just to teach yourself. Thank you.
Now I invite Dr. Sandeep Salvi, sir. He needs no introduction. He will enlighten us now on the further on oscillometry. You all know he is the founder director of Chest Research Foundation, and he is also member Board of Directors Gold, International Advisory Board member of Lancet Respiratory Medicine, and chair Chronic Respiratory Diseases Section, Global Burden of Disease, India. He has many publications. He is one among the top 1% of the respiratory scientists of the world. Over to you, sir.
Thank you. Thank you so much. For all the young pulmonologist students and the future consultants in the field of respiratory medicine, I can tell you with all sincerity and honesty that oscillometry is predicted to become the future of lung function testing. So you're a very lucky people to be in the right place at the right time to listen to perhaps one of the important diagnostic tools which will change clinical practice. It is not going to replace spirometry soon. It is going to complement spirometry, but it has a lot of added features, added value over spirometry. Simple test to perform compared to spirometry, normal tidal breathing. I mean, what can be easier than normal tidal breathing? So somebody the other day asked me, what are the contraindications for doing lung oscillometry? And the question I asked them was, what are the contraindications for breathing? Because that's all that you need to do in this test. So there are no contraindications for oscillometry. It gives you mechanical properties of the lung which spirometry does not. So it gives you a lot of information of what is happening in the distal portion of the lung. The small airways, the lung parenchyma, the interstitium. Spirometry does not give you too much information related to that. So these are the two unique advantages. What I'm going to cover over the next 15 to 20 minutes are just going to share with you some important aspects about how to interpret oscillometry. But before we go into that, there's always been this concern. Do we have normal predicted values for our Indian population to have confidence in our interpretation of oscillometry? And this stems from the fact that if you have to interpret spirometry, you need to have you need to have a predicted equation. A predicted equation that has all these variables within it: gender, age, height, weight, ethnicity. The reason for that is these are all very important determinants of what should be your spirometry indices. Because we know that spirometry indices change with age, they change with height, they change with weight, they change with gender, they change with ethnicity. Together they contribute to about 80 to 90% of the variability. And therefore, for a test like spirometry, you must have a predicted equation for you to compare your observed values with. Right? So without that, I mean, others, how will you know what is normal and what is not normal? Now, with this logic, my PhD student, Nitin Vanzare, he's now got his PhD, studied for 5 years to understand what is the predicted value for oscillometry, impulse oscillometry for the Indian population. 1,200 randomly selected people from the community. For one person, he had to screen 10 people. So it was a lot of hard work. And after 5 years of his immense hard work, when he pulled all the data and he started looking for the predicted equation that he generated, he was very upset and depressed. Because all these parameters that contribute to 80 to 90% of the variability in spirometry, they were contributing to only 10 to 20% of the variability. What do I mean by that? Age did not make a difference in oscillometry. Whether you're 30 years old or 40 years old or 50 years old or 60 years old, didn't make much change. Height made a little bit of change. Gender made a little bit of change. But together they contributed to only 10 to 20% of the variability. And then he said, oh my God, spirometry, you have 80 to 90%. Here I have only 10 to 20%. Maybe my quality of work was not good. When he compared this with the predicted equation generated by others from other parts of the world, they also showed the same thing, 10 to 20% of the variability. Good or bad? You know, sometimes when you're walking on a road, you stumble on a piece of stone, you fall down, you get hurt, and then you start cursing the stone on which you fell down, right? Sometimes you should pick up the stone and see what is beneath it. Many a times it will show you that there's a gold coin that is stuck, on the other side of the stone. You tripped because you were supposed to get that gold coin. That is exactly what happened to this PhD student. Because he fell down, he's saying that, he got a very bad quality predicted equation. This is another way of looking at it. What is your predicted blood pressure? So do you need to have your age? Do you need to have a gender? Do you need to have your height, weight to have your predicted blood pressure? No. You have a single cutoff value. Same thing for your blood sugar level. Do you have to have a predicted blood sugar level for your age, gender, height, weight? No. You need a single cutoff value for your blood sugar. So we said maybe for oscillometry, we don't need predicted equations. We need simple cutoff values. And this is exactly what we did in a preliminary study through the lead study that Disha just mentioned about. And we were pleasantly surprised and fascinated to see that there is a good logic for a cutoff value for oscillometry. You don't need a predicted equation for oscillometry, at least for the adult population. You need single cutoff values. And these are the cutoff values that we have generated based on our Indian data, which is not very different from what others also have reported from the western part of the world. There's plus minus here and there, but this is a unique advantage of oscillometry over spirometry. No need for a predicted equation in the adult population. A single cutoff value like your blood pressure, like your blood sugar. Now this is going to enhance the application of oscillometry immensely in clinical practice. Now Disha talked about the different parameters that we use in oscillometry. So you have the R5, the R20, and the R5 minus R20, the resistance parameters, and these are the cutoff values that we have generated for the Indian population. The unit that we have used here is centimeters water per liter per second. There are two ways in which the units are used, either in centimeters water, or you can use kilopascals per liter per second. The formula for converting from centimeters of water to kilopascals is given over there, just multiplying by around 10. Reactance parameters, the most important ones are X5, AX, which is the area of reactance, and the resonant frequency. And these are the cutoff values that we have generated for the reactance values as well. We have just recently submitted a report which has been accepted for publication, which is in press, should be published anytime soon, where we argued for this fact that we do not need predicted equations, we need simple cutoff values for oscillometry. And this should be published hopefully in the next 1 week in European Respiratory Journal. And this is the first time somebody has actually advocated for the use of single cutoff values. Now for adults, we don't need a cutoff value, but for children we do. Because as the child grows up to the age of 15 to 18, there are changes in the resistance values, there are changes in the reactance values. So for a child who is 3 years old, the resistance values are very, very high. I showed you for the R5 for a healthy adult is 4 centimeters water per liter per second. For a 3-year-old child, it is 12 centimeters of water per liter per second. And as the child grows older, it reduces from 12 to 10 to 8 to 5 to 4. And at 5 it stops, at 4 it stops, and then it remains the same for the rest of the life. More or less the same thing happens with reactance values. Earlier they are more negative. If you remember the number that I showed you for X5 is minus 1 centimeters of water per liter per second. So somebody who is 3 years old has a reactance value of minus 8. And as they keep on growing, it becomes less and less negative from minus 8 to minus 6 to minus 4 to minus 1, and then remains uniform, just like what I've shown you over here. So resistance values reduces with age, and the reactance values become less and less negative with age. So this is by and large what I mean by the normal ranges for oscillometry. Up to the age of 15, you need an equation. After the age of 15, you need simple cutoff values. So the report that we get in oscillometry, the first thing that we get is called as an oscillogram. An oscillogram is a graph that tells you about resistance parameters and tells you about reactance parameters. Now the resistance parameters that have been discussed are essentially R5 and R20. So resistance is on the upper portion of the oscillogram. Reactance is on the lower portion of the oscillogram. Above 0 is resistance. Reactance in the initial portion is below the 0 line, and the later portion is above the 0 line. Okay? So if you can see that this is the x-axis, which shows you the frequency of the sound waves that are being passed. So 5 hertz, 10 hertz, 15 hertz, 20 hertz, and so on. As you increase the frequency, the resistance from 5 to resistance at 20 remains a straight line. Resistance is frequency independent. Whether it is 5, 10, 15, 20, it should be a flat line, straight line. Okay, that's what happens in a normal, healthy individual. And how much should this be? For an adult, this should be 4 centimeters of water per liter per second and remains uniform for the rest of the life after 15. Reactance has got a negative component. The X5 is negative compared to this 0 line. And as the frequency increases, it starts joining this 0 line. The point where it connects to the 0 line, this point is called as the resonant frequency. So where the reactance, this component is the compliance or the elastance portion of the reactance, and above the 0 line is the inertance component of the lung function, of the respiratory system. So when the inertance and the compliance, they perfectly balance out each other, this portion is called as the resonant frequency. Okay? Before the resonant frequency is your area of reactance, this triangular portion. And this triangular portion is a very important portion of the oscillogram that tells you what is happening in the distal portion of the lung. Small airways alveoli, interstitium. All that information is hidden within this area of reactance. Okay? So based on this oscillogram, what are the parameters that we look for? In resistance, there are three: R5, R20, R5 minus R20. R5 is the entire respiratory tract. R20 is upper airways, large airways. And R5 minus R20 is small airways. As simple as that. Okay, I'll show you some examples later on. So resistance is only three parameters. Then resonant frequency, area of reactance, and X5 are the three reactance parameters that are important from a primary analysis point of view. More recently, we have started finding that if you measure the reactance at 5 Hertz during inspiration and the reactance at 5 Hertz during expiration, it gives you very useful and meaningful interpretation to distinguish between obstruction and restriction. And I'll show you some examples where by looking at X5 inspiratory and expiratory, that is giving you the answer whether this is obstructive or restrictive. So we'll go into that with time. And then delta X5 is just difference between inspiratory and expiratory X5. So let's do this simple exercise. Let's see how many of you all have understood what we have taught so far since on oscillometry. Now on the left hand side, I have put the cutoff values for R5, R20, R5 minus R20, and I've shown you the actual measured values and the proportion as compared to the cutoff values. So R5 value is increased 54%. R20 is also increased 70%. But R5 minus R20 is normal. Is there obstruction? And if so, where is the obstruction? Is there obstruction in the first place? Yes? Okay, good. Where is the obstruction? Only large airways? Well done. Very good. Okay, second example. R5 value is increased. R20 is normal, relatively normal. But R5 minus R20 is significantly increased. Is there increase in the resistance? Yes. Where is the obstruction? Very good. Pure small airways obstruction. R5 is increased. R20 is increased. R5 minus R20 is also increased. Is there obstruction here? Yes. Where is the obstruction? So R5 is total. R20 there is obstruction. R5 there is obstruction. R5 minus R20 also there is obstruction. So this is both large and small airways obstruction. By looking at R5, R20 and R5 minus R20, it will tell you where the obstruction is. As simple as that. Now this is how an oscillogram looks like in a patient with asthma. So this blue is the dotted line, which is the normal reference line for a healthy adult. This dotted line is the reactance line. So you can see this is R5, R20, it's a flat line. In this patient, pre-bronchodilator is this line and post-bronchodilator is this line. So let's focus only on resistance values now. So what has happened to R5 value in this patient compared to the normal value? This is 4. So what has happened to the R5 value? Increased. What has happened to the R20 value? Is also increased, isn't it? What has happened to R5 minus R20? There's a delta over here, isn't it? Normally it should be close to 0, but there is a difference between R5 minus R20. So R5 is high, R20 is high, R5 minus R20 is also high. So where is the obstruction? Everywhere. After giving a bronchodilator, 2 puffs of salbutamol, you do oscillometry, R5 value has come down. What has happened to the R20 value? Come back to normal now, isn't it? And R5 minus R20 is still high. So whenever you get a pattern like this, high R5, high R20, but after giving a bronchodilator, R20 comes back to normal, R5 also comes down. This is what we find in asthma. Okay? If you look at the reactance lines, so this is the normal this light green over here is the normal reactance. So this is the resonant frequency. This is the area of reactance in a normal healthy individual, this triangular area. Pre-bronchodilator is this one now. Look at the area of reactance. What has happened to the area of reactance over here? Big in size. What has happened to the X5 value? So X5 value is here, -1 in a normal healthy individual. Now it has become -2.6. So X has become more negative. Area of reactance has become big. Resonant frequency has shifted to the right. And after giving a bronchodilator, all these things have become small. So the area of reactance has now become smaller. The resonant frequency has shifted to the left, and AX has also gone higher up. So this is what we find in patients with asthma. In COPD, this is the oscillogram that we get. Again, this is the normal line for a healthy individual, this one and this one. So what has happened to R5 in this patient? Increase. What has happened to the R20 value? Normal. Why do we get a normal R20 value in COPD? Because COPD is a disease that primarily affects only the small airways. Large size airways are not usually affected in COPD. So R20 is normal, R5 is higher. R5 minus R20 becomes a very big number then, which tells you that the small airways are predominantly affected. After giving a bronchodilator, see the amount of improvement that takes place. Small change in R5 and R20, there's actually no change. But if you look at X5 now, so this is the normal X5, it has become more negative. Remember that the distal portion of the COPD lung, both the airways as well as the lung parenchyma, because of that, they become more negative. So X5 has become more negative. The resonant frequency has shifted from here to the right over here, and the area of reactance has become very, very big. After giving a bronchodilator, you can see that there is a bigger change in the area of reactance as compared to what we find in the resistance parameters. So this is what we classically find in patients with COPD. Okay? Now Dr. Atri did his first patient in a 2-year-old child. I must say that we have lost the competition. We did this in a 3-year-old child. And this was a 3-year-old child whose parents both were engineers. He had 3 hospitalizations for respiratory related problems. And at all the times, the doctor did hint that his son has likely asthma and he's getting hospitalized for asthma exacerbations. The parents refused to accept the diagnosis because they said, give me a proof that my child has asthma. I don't want to start my child on inhaled corticosteroids for no good reason. Can you do a test that will confirm the diagnosis of asthma? So here, this is a test that was performed on the impulse oscillometry. You can see that there are 2 graphs over here. One is for resistance, one is for reactance. Here the resistance, you can see the units are in kilopascal units per liter per second. So you have to multiply this by 10 to get it into centimeters of water. So for your simplicity, I have converted all these values from kilopascal units per liter to centimeters of water here. So R5 in this 3-year-old child was 15.4. What should be the normal value? So let me show you that. So here is a 3-year-old child. For a 3-year-old child, the normal R5 value is how much? 12.2. Is 12.2. And what we found with him was 15.4. So his R5 value is increased. After giving a bronchodilator, look at that drop in the resistance just with 2 puffs of salbutamol. That's an impressive drop in R5, isn't it? So R5 was high, R20 was relatively normal in this child, but nonetheless there was a good bronchodilator response. Look at the amount of bronchodilator response that we had. Look at the reactance also. Look at the X5 pre-bronchodilator, huge minus negative. It was, how much was it? From minus 8.15. And after giving a bronchodilator, it improved to minus 5. You can see that the area of reactance, this whole triangle, was 80.2. What is the normal value in an adult that I showed you? 4. In this child, it was 80. After giving a bronchodilator, it reduced to 38. So I think by just looking at this graph, we were confident to tell the parents that your child has asthma. And the parents were convinced this time. They said, okay, now we will start a child on inhaled corticosteroid. Look at the application that this has in clinical practice. Which 3-year-old child will do spirometry in our clinical practice? So that's one of the advantages. Okay, here's another case. 58-year-old female, obese, as you can see, known asthmatic for quite some time, but for the last 6 months, she has been needing oral corticosteroids for her asthma control, oral corticosteroids. The moment she stops the oral corticosteroids, her asthma flares up. And therefore, she has to be on constant dose of oral corticosteroids. The physician recommended her that she would need to be started on benralizumab. She got a little scared. How should I spend so much of money, so many lakhs of rupees for an injection for which I may or may not benefit? So she came to us for advice. So we did her spirometry first, and you can see this is 3 pre-bronchodilator, 3 post-bronchodilator. You can see that there's a good bronchodilator response, 18%, 270 ml in FEV1, which is what we would have otherwise have expected. But when we did her oscillometry, see her resistance and see her reactance lines. So if you want to see the values over here, again, for your simplicity, I have converted them into centimeters of water, and here are the predicted, the cutoff values, which we have generated. So if you look at her R5 value, which is this pre-bronchodilator one, was 9. What is the normal cutoff value? The upper cutoff value is 4. So she's almost double of that, more than double. So R5 value was very high, but after giving 2 puffs of salbutamol, she almost dropped back closer towards normal. Look at the R5 minus R20. From 5, R5 minus R20 should be less than 1. This is 5 times increased. And after giving up 2 puffs, I mean, she did so very good bronchodilator response in the small airways. Similarly, look at the reactance value. X5 went so negative. Her X5 was minus 5. After giving a bronchodilator, it came to minus 2. And her area of reactance from 62, it came down to 11. Now, what does this mean? Yes. So we asked her, ma'am, which inhaler do you use? So she was using Pulmicort dry powder inhaler. Can you demonstrate how to use it? And when she demonstrated, we got a shock of our life. Did nobody teach you how to use the dry powder inhaler correctly? She said, but my doctor taught me how to use this way. So we replaced that dry powder inhaler into an PMDI with a spacer. You know which PMDI we gave this time? Because we believe that she has got small airway dysfunction related asthma, SAD asthma. So we gave her small ultrafine particles, Nivioli. So we gave her a Nivioli with a spacer, and she improved dramatically after that. She did not need to be put on benralizumab. See the application of oscillometry? Something that spirometry wouldn't have given me that confidence to say that there's something wrong in your inhalation technique, or you need to be put on a different class of drugs. Now, one thing that I wanted to show you over here is if you look at the X5 inspiratory and the X5 expiratory, that also gives you a very important message. The obstruction that we get in asthma or the obstruction that we get in COPD, is it difficult to inhale or is it difficult to exhale? Exhale, right? So if you look at the exhalation X5, it becomes more negative as compared to the inhalatory X5. Ideally, inhalation and exhalation X5 should be very close to each other. There should be hardly any difference. But if your exhalation X5 becomes more negative, that means there is some very strong obstruction that is a predominant problem over here. And why this is important, I'll show you in my subsequent slides. How do you define a good bronchodilator response? For FEV1, it is 12% and 200 ml. What is it for oscillometry? So those good bronchodilator response parameters are still evolving. As of now, tentatively, this is what is being recommended. If your R5 value reduces by 40% and your AX value reduces by 50%, that's a good enough cutoff value to say that this is good bronchodilator reversibility. However, we now need to generate our own bronchodilator cutoff values. Another very interesting case. So 48-year-old female professional singer, she took part in the radio program of Idol, Young Idol or something, absolutely brilliant singer. And she said, doctor, for the last 3 months, I've been coughing. I have not been able to sleep in the night. I've been taking so many different cough syrups. Doctors have prescribed me so many antibiotics and nothing is working. Then I said, did any doctor make a diagnosis of asthma? No, not a single doctor has made a diagnosis of asthma. I said, okay, let me see what we find on spirometry. So we did her spirometry over here, And we found that, look at the bronchodilator response, plus 7% and 120 ml. It didn't tell me much. Is this asthma? Historically, from a history, I could suspect that this is asthma because her mother had asthma. And as a child, she had allergic rhinitis and eczema. So, but she said, sir, I'm a professional singer. I really can't afford to take the wrong medication because it will affect the quality of my voice. So we did oscillometry in this patient. And you can see the resistance values and the reactance values, the pre-bronchodilator resistance, the post-bronchodilator resistance values, and the same for reactance. What is the message over here? What spirometry could not pick up, oscillometry could pick up a diagnosis of asthma. So there was small airway dysfunction related asthma with reasonably good bronchodilator responsiveness, as you can see here. From 41, it came down to 13. So this is clearly more than 20% improvement after a bronchodilator. So after the oscillometry report, we started her on inhaled corticosteroids, and now she is a lot better. Now just to show you the difference between X5 inspiratory and X5 expiratory, here are two graphs, and here are the inspiratory and the expiratory values. Now here you can see that X5 expiratory is more negative than X5 inspiratory in this patient. So this is classically R5 is increased, R20 is normal, R5 minus R20 is huge. What is this likely to be? COPD. Very good. Look at X5. Huge decrease in X5, and the area of reactance is a very big triangle. Resonant frequency has shifted from here to here. And in this patient, expiratory X5 was more negative than inspiratory X5. Now in contrast to this patient, see this patient. The resistance value at 5 is slightly increased, R20 is normal, no bronchodilator response. Reactance is at the edge over here, well, nothing much. But look at the difference over here. X5 inspiratory is minus 3.3, X5 expiratory is minus 1.2. It's the opposite of what has happened over here. So when your inspiratory X5 becomes more negative, that is indicative of interstitial lung disease. So that is how you use X5 inspiratory expiratory to say this is obstructive or to say this is restrictive. And this was first reported by the Japanese group in 2013, which clearly shows that in interstitial lung disease and COPD, the delta X5 is they're opposites over here. So you get expiratory more negative, inspiratory more negative in ILD. So I think that's something very important. Post-TB lung fibrosis, how does it look like on oscillometry or an oscillogram? Increase in R5, reasonably normal R20. So something is happening in the distal portion of the lung, poor bronchodilator responsiveness, small airways are affected, and the reactance values, you can see something huge, massive happening here. More negative X5 with poor bronchodilator reversibility. And this was the X-ray of that patient. So gives you a very reasonably good indication of what is actually happening from a physiological and a mechanical point of view in terms of breathing. This is the last slide that I wanted to show you, that spirometry just tells you about vital capacities and flows. Oscillometry tells you about resistance and reactance. Then I told you that reactance can be inspiratory, can be expiratory. Wow. So even intra-breath, during inhalation and during exhalation, what are the changes the mechanical changes, properties that are changing in your lung are also being seen on this. And here is an example of how inhalation, resistance at 5 Hertz during inhalation, resistance at 5 Hertz during exhalation, and the reactance values. Now this is something that is evolving. Intra-breath oscillometry analysis is something that is evolving very rapidly. And that is going to harness this new discoveries and new inventions about how this simple test of normal tidal breathing is going to give us such valuable information about the lung. So I'm going to stop over here. And as I said, I genuinely believe that oscillometry is going to be the future of lung function test. As of now, I would not recommend all of you all to replace oscillometry from spirometry, but use oscillometry as a complementary tool. Do spirometry and do oscillometry. It will give you additional features that spirometry does not. But I'm sure that over the years, SAD asthma is going to be an extremely important phenotype of asthma that will need to be treated. But how do you know whether that asthma is SAD asthma or happy asthma? The best tool that will give you that answer is oscillometry. And if oscillometry tells you that it is SAD asthma, the treatment changes completely. You need to give them ultrafine particles, and that's a game changer in the field of SAD asthma. What proportion of asthmatics have SAD asthma? More than 50%. These are patients who have severe asthma, uncontrolled asthma, nighttime awakenings, multiple hospitalizations. These are very, very classical patients who have SAD asthma. To pick them up on oscillometry is going to be very simple, and their treatment and their life can change completely if you give them the right treatment after making the right diagnosis. Thank you so much.
Thank you, Dr. Sandeep. With the previous talk, we thought it was spirometry versus oscillometry, but now with your talk, it's more evident that both are not enemies rather than friends, and it's a complement each other, and exclusive information we get from oscillometry will help us to refine our clinical decisions. Are there any current guidelines which include oscillometry as a routine part of clinical
So
practice?
those guidelines are still evolving. What is happening now is there is a standardization that is happening. So there are different types of oscillometry devices. At least outside you will see there are 2 or 3 different types of oscillometers which we'll be having over here. Which one is better than the other? And that was a question that was asked. So, all of them give you the same information, more or less the same information. The time that it takes to do an oscillometry test varies from 24 seconds to 36 seconds. The cost varies from around 3 lakh rupees to 12 lakh rupees. But more important than that, I think, as I said in my first presentation, we need cutoff values. And we need to generate the cutoff values independently for each device. So we have generated the cutoff values for the Antlia device because we started research on that. So we have now cutoff values for the Antlia device. Others will now have to develop the cutoff values for the impulse oscillometry or for the tremoflow or for the pulmoscan, and that is going to take some time. There might be very little differences in the cutoff values, but they need to be generated because the different machines don't give you exactly the same values. So an R5 value that you get with an Antlia will be different from an R5 value that you get with an impulse oscillometry or with a tremoflow device. So each device will then have to derive their own cutoff values. So that's one of the challenges that we face. But by and large, all of them they're all good.
So for the young pulmonologist attending the conference, with a word of caution.
Okay. Sorry, who? Yeah. The Z value, the Z score. So if you remember that.
Call me about the Z value of that patient.
Okay. So if you saw the title of the sorry. So this is a paper that I said is in press, should be published anytime. Interpreting lung oscillometry results, Z scores or fixed cutoff values. So here we have actually argued we should not use Z scores in oscillometry. In spirometry, yes, you should use Z scores because all those parameters, FEV1, FVC and all, they're all normally distributed. Whenever there is a normal distribution, then the Z score becomes reliable. But if your values are not normally distributed, if you look at the R5 values, they're not normally distributed. If they're not normally distributed, you cannot use a Z score value for that. And that is what we have actually argued in this. So interpretation of oscillometry will be now without the Z score values. It will be based on simple cutoff values.
Because some centers are giving reports with that graph.
That will all change with time. No? Okay.
Thank you, sir. Thank you for enlightening us more about the impulse oscillometry and more questions as we practice. Thank you for the opportunity.
Thank you, speakers, and thank you, moderators, for this insightful session on lung oscillometry. Now I'd like to invite Dr. Ravi Kiran, Chief Operating Officer of Yashoda Hospital, High Tech City, and to come on a desk and carry forward the session.
Good afternoon, everyone. On behalf of Yashoda Hospitals, I would like to extend a warm welcome to all the eminent physicians who have come here as faculty and the delegates. Yashoda Hospital started its journey in 1989 as a 50-bedded nursing home at Somajiguda. Over the past 30 years, it has developed to be one of the leading healthcare provider in Hyderabad and a sorry for that. And it is becoming a very popular brand across the country. This now, over the past 30 years, starting from a nursing home, it has evolved as a 4 hospital chain, and now we have around 4,000 beds under the Yashoda banner. This success was possible because of the world-class treatment that is being provided by our clinicians who have come from reputed institutes across the country, the latest and advanced technology which is being provided to improve the patient outcomes, and a razor-sharp focus on patient-centric services. Yashoda High-Tech Unit is a 2 million square feet facility with 2,000 bed capacity. Each floor plate can accommodate around 4 Boeing 737 aeroplanes. There is around 40,000 square feet of green coverage that is present across the building. Light wells are cut at various places so that natural light can come into the interiors of the building. There is a biophilic interior design that is being used in the planning of this facility, because our chairman, G. Ravindra Rao sir, believes that sunlight and fresh air are very important in the healing process. You can see this across the various aspects of the facility. The air conditioning that is provided has got treated fresh air that is drawn in from the atmosphere, and we have ensured that every room has got huge windows so that it gives a better patient experience. We have got a 1 acre garden on the 7th floor where patients with long-term illness can actually spend good amount of time and not feel sick of being in a hospital. We have 28 lifts, 31 OTs in this facility, and coming to technology, we have got the latest RoboXI system to do robotic surgeries. We have got a 3 Tesla MRI, the Kinova interoperative microscope, which is integrated with navigation system. We have got 4 cath labs, including 1 hybrid cath lab to do advanced procedures like TAVR. In pulmonology, we have got lung point, bronchothermoplasty, CPET, body box, etc., which you'll be seeing tomorrow when we do the inauguration of the advanced PFT lab. Along with facility and the equipment, we are partnering with clinicians of great repute so that we can build centers of excellence in this facility. Though we have built a world-class facility, I would like to mention here that we are sensitive that healthcare is a price-sensitive industry, and we have kept the pricing at this unit similar to what that is there in Somajiguda and Secunderabad, so that it is an affordable healthcare system. With this, I would like to present a small video regarding this facility. I request you all to please watch it.
There will be a tea break after 15 minutes, so request you to please be in the places for some time.
As it is our tradition to do any auspicious event through lamp lighting, I request our dignitaries, Dr. Randeep Guleria, Dr. Sandeep, to please come onto the dais for lamp lighting. I request Dr. Pavan sir, Lingay sir to please come onto the dais, sir. I request Dr. S.K. Chabra, Dr. Richa Gupta, Dr. Subhakar Kandle, Dr. Sunil, please do come on to the dais. Dr. Arjun sir, please do come on to the dais for the lamp lighting. delegates.
Thank you, sir. So I'll just take 1 minute, not more than that. So the concept behind this PFT summit. So this is something which we are doing for the first time. We've done a lot of conferences earlier, focusing on pulmonology as a whole. Some focus ventured into earlier, that is the pulmonary function testing. So why PFT? Why is it important? As a pulmonologist, as we all know, PFTs have become an integral part of our day-to-day practice. So we use PFTs for diagnosing diseases, for monitoring the course of disease, for monitoring the response to therapies, for prognosticating a patient, as a part of pre-surgery evaluation, and the list goes on. So the reasons why you do a PFT is increasing. And you see reports being done at multiple centers, and it is very disheartening to say that 80% of the PFTs which I see which are done outside are not conforming to the technical standards. So the patient pays for the test, but the test is of no use. So it is important for any pulmonologist who is qualified, who is going into practice, is because of the plethora of equipment which are now commercially available and which are now accepted for clinical practice. I think 5 to 6 years behind, it was only spirometry which we had. Maybe some centers were doing DLCO, some were doing body box. But now if you list the number of approved acceptable tests which are there, I think the list is around 9 to 10 different equipments which can be done. So in these 2 days, as you have seen the schedule also, we are covering all these different pulmonary function test procedures other than spirometry also. As the sessions have started, we have 2 excellent sessions on spirometry and oscillometry, and we are having even better sessions in the afternoon and tomorrow also. And we're very lucky that we have the best of the best in India who have come and who are there to share their experience. So I would request all the delegates, participants to make use of this opportunity, interact with the speakers in the hands-on workstations, and improve their knowledge on pulmonary function testing. Thank you so much.
Thank you, Nagarjuna. Now I request Dr. Pavan, sir, our director, Yashoda Group of Hospitals. He himself is a pulmonologist and he has done pulmonary critical care. Sir, please address the gatherings.
Thanks, Ravi. It's true that I was a pulmonologist, but I think I'm forgetting now. So since last 5 years, I came back in February 2018. No more practicing pulmonary, only managing pulmonologists, which is even more problematic. Bronchoscopies seem easier, but anyhow, stuck. Working doctors definitely, timing wise and everything else wise too. So I'm sure you'll go much more enriched. A special thanks for all the dignitaries from all over the country to be here. Yes, as Nagarjuna was saying, it's not usual. Even I was surprised. Wow, full 2-day sessions for PFT is but you know what, yes, everything is specialized now and there are so many doctors graduating, so I think we have to be ahead of the curve. So no, everybody cannot do everything. I mean, everybody should know everything, but at least a little bit of what is happening. But I mean, there is a lot of specializations happening, as you know, in intervention pulmonary, in transplant pulmonary, and but even more the bread and butter like PFTs. There is a lot of scope. I mean, yes, it's true. When I was in pulmonary too, just the spirometry, DLCO, just peripherally used to see a little bit of oscillometry, but a lot of improvements have happened. And if you do practice this for each of your patient, normal people, sick people, and also it gives a lot of information, PFTs, and maybe cardiopulmonary exercise stress also will take up in a bigger way. Like, but next 5-10 years, I think this will become more important, and because so many medicines are coming to, we just need to tailor personalized therapy. Will depend on first identifying what is disease. Many people complain of breathlessness. Should I go to pulmonologist, cardiologist, or still that questions are there? But I think just to prove the cardiologists that they need to come to pulmonologists, we can show some spirometry graphs or something. So I think here, I'm sure, as Nagarjuna was saying, I'll just reiterate the same things, is please don't feel shy to ask any questions, smaller, bigger, and all. It starts with, everybody starts with humble beginnings only. First central line for me was very tough. Like in US, I thought I had no experience. They said, okay, put a central line, but I had no experience. I said, okay, then okay, see one, put one. That is one kind of learning, but I think it's better is to have a structured session like this. Please keep asking questions, and more importantly, do this for all of your patients or many patients, and then you'll get to know more about routine PFTs to what exactly it shows. Okay, Venkat, you come into pulmonary conferences also. That's welcome. Great. So what else? Yes, for the people out of town and all, we built a new hospital here. But definitely it looks 5-star, but costing is not 5-star. I can guarantee. If anybody has come from outside, feel free to check. If you want to stay in a room here or our suite rooms, definitely will be cheaper than a hotel. And I can guarantee. So personally, you can experience the services and all. Only the service is 5-star, but the charges and all is pretty reasonable. So, I mean, just because everything is becoming specialized and healthcare is becoming first world, I can confidently say that I've been in multiple hospitals in US, but I think the top corporate hospitals here, look-wise, facility, infrastructure, everything is equalizing to the other countries. So doctors are also equally skilled. So I think many people can, I mean, I've been to 20 countries in Africa, Uzbekistan, Kazakh, Vietnam, and Indonesia, and all of these places. But everywhere, though, healthcare is at least 10, 15 years behind India. So I think in future, they'll have no option but to look at the country in a bigger way. So I think that's why we are a little ahead of the curve too, like a state-of-art facility. Feel free to walk by anywhere, like pulmonary rooms, ICU too. Each one is cubicle, individual cubicle styles. We have some, eventually we'll have some 400 of those, separate ECMO ICU, separate lung transplant, separate liver transplant, and all this kind of thing. So because all of our other 3 hospitals, we had to renovate at least 4 or 5 different times, taking a lot of time and effort. So hopefully this hospital will not renovate at least for 10 years or so. We built it for the next 10 years. So whenever you have some time, you feel free to walk around anywhere. And I'll not take too much of your time. This is a high quality session with high quality speakers. Make use of this. I mean, pulmonary, I should say, is some people are saying I'm favoring pulmonary because I'm a pulmonologist. No. It's only in my admin hat. Pulmonary department is doing very well. And nowadays, all those malaria and regular fevers and all have come down. So it's COVID, influenza, whatever combination of ECMOs, critical care, and the bread and butter pulmonaries keep on increasing. So you're in the right field, but you had to be ahead of the curve to be like in the people in the front rows here. Special thanks to Dr. Guleria Sabanda, despite his busy schedule, spending 2 days in Hyderabad. So, and everybody else, all the top class people here, please make use of this opportunity to be more interactive. Pulmonary, I think I don't even need to go through the country. Everybody is in Facebook and whichever, but physical interaction also has its advantages. So please make use of this opportunity. Thank you very much.
Thank you, sir, for your words. Now, coming to the most important part of the inauguration program, the keynote address. As we all know, the person who needs no introduction, Dr. Randeep Guleria, Sir happens to be the first DM pulmonary medicine in the country. Sir has been awarded many awards, including Padma Shri in 2015, the BC Roy Award by the IMC, IMA, the National Excellence Award. To his credit, he has more than 470 publications, 50 chapters, 54 research grants. The list is unending. Sir happened to be the member of the National Task Force and the Empowered Group for the Government of India for the COVID-19 pandemic scenario. He was also the personal physician to the Prime Minister of India from 1998 to 2004. Sir is now the chairman for the Institute of Internal Medicine and Respiratory and Sleep Medicine, and he's the director at Medanta Medical School also. Sir, please do come onto the dais to give you a keynote, sir.
Good afternoon. At the onset, let me take this opportunity to thank the organizers, especially Dr. Nagarjuna. So what I was asked to talk on was basically the evolution of pulmonary function test and how it evolved with time. And it's very interesting if you go to the fascinating history as far as lung function is concerned. So if you look at how it all started, maybe if you look at it centuries ago, man has tried to understand the function and mechanics of respiration. It's something which has always fascinated humans from the very beginning. Actually, Greek philosophers thought that lung was to temper and cool the blood which was going into the heart. So it was felt that the main function of the lung at that point in time was just to cool the blood which was going into the heart. Aristotle, as a matter of fact, felt that we had only one lung, and he had proposed that there was only one lung that existed. Galen, way back, collected exhaled air in an artificial bladder and believed that the lung was meant to carry off vapors, which was causing pollution. 17th century actually revolutionized the understanding of lung function, and then we had the detail of the pulmonary circulation in 1628. So if you start looking at the whole history, in 1667, Robert Hooke actually kept a dog alive by artificial respiration with bellows. And then subsequently, we had the look at inspired air. Humphrey Davy and James Watt actually first devised something which was known as a pulmometer to look at what was subsequently to become lung function, which was actually attributed to John Hutchinson, who published the work and called it a spirometer. He also, coming from a background where he was an insurance agent and good in statistics, was able to really establish that spirometric values were actually dependent on age, height, and that was what actually mattered as far as vital capacity was concerned. So the early attempts, like I mentioned, Humphrey Davy tried to measure residual volume by inhaled oxygen mixture containing mercurial air holding. Nestor Grahant also tried to determine FRC. And if you look at the traditional old machine, this was the Humphrey Davy and his colleagues' pneumatic machine, which was actually very similar to what Hutchison developed. But they had developed it as a machine to look for lung functions almost 48 years prior to Hutchinson's spirometer. But the primary work that was actually done by John Hutchison. And he was a surgeon. He actually worked as an insurance consultant for a life insurance company, Britannia Life. And this was something that he did as a part of understanding lung functions or respiratory functions. And he tried to really look at the capacity of the lung. This is actually a seminal article which was published in 1846. And this was called The Capacity of the Lung and the Respiratory Function. And he tried to establish lung function as we know it today and developed a spirometer. So what he did was, this was the initial spirometer. He had this counterbalanced bells which were out there. Along with that, this was immersed in water, and something that we even now have if you look at your old spirometers. And
actually attributed breathing into the tube, which resulted in measurable displacement of the bell, and this was how you could calculate the vital capacity. And he did this study in around 2,130 individuals, and these are the individuals that he examined. This was his sort of population to really try and come out with the data. He looked at sailors, fire brigade members in London, police members, paupers, even the Royal House Guards, and even giants and dwarfs. And he had this sample size of 2,130 individuals that he examined to what we have. The terms that he used was residual air, which is now known as residual volume, reserve air, which is now known as expiratory volume, breathing air, which is known as tidal volume, complementary air, known as inspiratory reserve volume. And he coined the term vital capacity, the greatest voluntary expiration following the deepest inspiration, and he called it the capacity of life. He also said this, that of the vital capacity, this differs in man according to height, weight, age, and disease. And therefore, probably that was the first time that someone really documented what pulmonary function test was all about and gave terminology to simple things like tidal volume, IRV, ERV, and vital capacity. This led on to a lot of subsequent evolution. We had from 1819 to 1930 different devices which came into place as far as spirometry was concerned. There was modification which happened to the Hutchison spirometer, which led on to newer type of devices using both air and water, and this led on to what was known as the Baumann spirometer in 1864, which was actually based on a plan of dry gas meter, and this was simpler and more accurate to use as compared to what Hutchison had described. GW Baumann spirometer was subsequently patented also as part of a device which could be used for lung function. And then we had what was known as Kesela's spirometer in 1872, which had a dial which could really, you could dial up and see what was there, the volumes that was there. So finely balanced circular air sail, there was a finely balanced circular air sail which drives the hand over a dial, the dial out here, and this dial showed the force amount of respiration and the capacity of the chest. And this led to various processes, lung function being, this spirometry being used to strengthen the lung, various types of spirometers got described as far as this was concerned. But despite all of these advantages, or all of this research that went on in developing devices, spirometry remained an experimental and ancillary tool till the early 1900s. So there was a lot of these devices which came up, but for physicians to use them as in their day-to-day practice, that did not happen for quite some time. And then from 1920, we saw what has been known as the golden era of spirometry, where things really started happening more from the clinical application point of view. So in 1920, George Dyer actually made use of spirometry in pre-op thoracic surgery assessment and for evaluation of occupational lung disease. So he started looking at this from the point of view of clinical applications. In 1930s, it was look at the response of epinephrine in asthma and emphysema to look for reversibility. And then we had a classical paper from France, I'll come to that later, by Tiffany and Pinelli, who actually described the FE1 by FVC ratio, and it got lost for many years. And then we had the flow volume curves. So George Dyer actually in 1920 started using spirometry for preoperative thoracic assessment for thoracic surgery, occupational lung disease, aviators lung disease in World War II, and he also started using it for asthma and emphysema. Alvin Bark actually started using expiratory flow rate with using nebulized epinephrine in asthma and emphysema, and he actually first published the bronchodilator effectiveness. So a lot of sort of seminal work was done during this time. And then we had the paper which looked at the classification of disease as obstruction or restriction, and Tiffany and Pinelli in France published in French the concept of FEV1. And they actually called it the Tiffany-Pinelli index, the FEV1 by FVC ratio. So this was actually coined by them, they called it this ratio, and this was lost in translation because this was published in a French journal for almost 5 years. And subsequently, in 1951, it was shown that FEV1 closely correlated with the maximum breathing capacity. We had subsequent evolution as flow volume loops are concerned by Fowler, looked at FEF by 25 to 75, trying to see whether this was something that could tell us about small airway disease. The peak flow meter came in as a simple test to really look at obstructive airway disease. And then you had the flow volume loop, and Mead et al. Actually tried to explain the dynamic flow limitation observed in the flow volume curves through equal pressure point theory. So all of this happened as a part of evolution as far as spirometry was concerned. The next big step that happened, so we had initial development with the spirometer by Hutchison, and then subsequently its development. We subsequently had this era starting from 1920, where we started looking at its utility in not just as something that could be done, but in various disease processes, and trying to look at various parameters in spirometry. And then we had an era where one started looking at standardization of spirometry. Now that we have this, how do we standardize it? In the 1960s and 70s, there was the FE1 and FEC could delineate between obstruction and restriction, and the flow volume loops came up. In 1979, we had the first standardization guidelines of spirometry by the American Thoracic Society. 2005, the ATS-ERS guidelines came, and 2019, they have been recently updated, and I'll come to that. So if you look at the PFT standards, they've evolved with time. So this is the era where standardization came into place as compared to what was being done in the past. From 1978, where we had the epidemiological standardization to spirometry, to I think the basics, first documentation of standardization which came in as far as 1979 was concerned, the Snowbird Conference of American Thoracic Society on Spirometry, which actually laid the foundation, and subsequently it got updated into various criteria as far as spirometry was concerned, up to the bronchial challenge guidelines in 2017. There were other standardization efforts for various activities from the BTS, Pulmonary Function Lab Manual, bronchial challenge testing, the 6-minute walk test, cardiopulmonary exercise testing. All of these came into a proper standardized format from the equipment point of view to the procedure point of view to the interpretation and how this could be done in a proper standardized manner. So this was the subsequent era which evolved into seeing how spirometry could be done in a proper standardized manner as compared to what it was being done in the past. We moved into the next era where we started looking at what was the prognostic potential as far as spirometry was concerned. And I think this was classically shown in the Framingham study that validated the prognostic potential of spirometry in cardiovascular disease and managing chronic respiratory disease. As a matter of fact, the one strongest parameter in the Framingham study which showed its correlation with heart disease was FEV1. So it showed the utility of looking at lung functions not only from the point of view of pulmonary diseases, but even from the point of view of cardiac disorders. And then Fletcher and Pito in their classical work showed the role of spirometry in diagnosing and management of COPD and how it evolves over time. Bronchodilatory reversibility became a standard thing in terms of methacholine challenge as for bronchial asthma. And there was monitoring of progression of disease in cystic fibrosis, and more recently prognostic indicators of IPF and monitoring lung transplant for graft rejection. So it started off with this paper which showed that FEV1 as a powerful diagnostic prognostic indicator for both pulmonary disease and cardiac failure, published way back in 1980, and the classical paper published in the British Medical Journal by Fletcher and Pito, which showed that the natural history of chronic airflow obstruction, classically trying to look at smokers who developed COPD and what happens if you stop smoking. So this started looking at how spirometers could be used from the prognostic point of view, and that was the next era where spirometers got more and more popular in terms of being used in clinical practice. We then moved into the next era where technology came in, and spirometers actually moved from hospitals or from labs into offices as far as this technology was concerned. And this was spirometers from lab to offices, the so-called electronic spirometers for office use. So adoption of spirometry in primary care was suboptimal until the 21st century. And this was conventionally a large hospital-based tool which all of us as residents, at least my generation, saw in the PFT lab. Big devices had to be standardized using a big syringe to see that it was properly calibrated. All of this actually changed when electronic spirometers came. And the National Lung Health Program promoted office spirometry. So this was another huge step that office spirometry became to be promoted. And what they really said was, test your lung, know your numbers, and this will help you in terms of how your health status is. There have been obstacles, lack of training, uncertainty about the test impact, and low confidence in its use. But it has now evolved into something that has come into office space. So this was the type of spirometers that we use. Even the rolling seal spirometer, the electronic rolling seal spirometer, was being used till very recently, the wedge bellow, and the water seal spirometer. This gave way to various other devices which looked at flow and various ways to measure lung function using various other modalities. The pneumotachometer came in, the ultrasound-based measurement, and the hot wire anemometer, where you looked at the change in temperature across the wire, and that could be converted from flow into volume, and that also helped in terms of converting what was a large spirometer which Hutchison had developed into something which became more and more hospital-based. So we had now spirometers which were classically simple, handy, electronic, and could be done even in an office setting. And I think this was the second evolution which happened as far as spirometry was concerned. From large PFT labs, it's moved on into office-based spirometry, which can be done. I won't spend much time, just one slide. A lot of evolution happened also in other parameters. In DLCO, classical work done on tonometer, microtonometer by Krog et al. In Denmark. They had a stamp also on their name, and this was something which led to the development of diffusion capacity. Lung volumes also evolved from what was in the early ways difficult and sort of devices to look at lung volume, traditional lung volume, which was developed as body plethysmograph devices. And I remember we used to have body box, which would be both looking at the classical body box, where the volume was standard, you had a given volume, to a body box where the pressure was standard and the flow would be there. So at the lower end of the body box, you had a bellow and the pressure would be maintained, but the volume would change. So those are the older body box, but it has evolved over time into a classical body plethysmograph. And along with that, there have been the current guidelines. This is the guidelines which came out as far as 2019 was concerned in terms of the ATS and the ERS technical statement for lung function. And more recently in 2021, we have the technical standards for interpretive strategies for routine lung function testing. So along with this, more and more guidelines and updates have happened as far as lung function is concerned. So from where we were to current, spirometry has evolved into something which has become more tech savvy, more easy to use, and something that will be useful at a very, very basic level also. What about the future? What do we think that will happen to spirometry in the future? I think from lab testing to home testing, to office testing, we will probably move to home spirometry, and home testing spirometry by patients will become something which will be possible. It will get linked to smartphone apps, and it's already happening. Usage guidance, performance feedback, cloud-based service for data storage will happen as far as spirometry is concerned. Smartphone microphones to generate spirometric measurements. You will probably be able to look at, we already have a device where you put it on to your smartphone. It has a small sensor, and you blow into it, and it gives you a curve on your phone, and that gives you an idea as to what is your lung function. So that is something that can be done by patients, and they could be taught to monitor their own spirometer. Pheno will also come into play in a big way, cheaper and more portable. So we will move from what was initially there as far as exhaled breath was concerned to Pheno, from clinical lab going on to GP practice and home-based, and then exhaled breath condensate, which will also become something that will become more and more easy to use, not only from a clinical lab, but also at a home-based lab or home-based equipment for exhaled breath condensate to really help you pick up a lot of such things. AI will come into a big way, and this is an interesting paper published which looked at artificial intelligence and showed that it outperforms pulmonologists in the interpretation of pulmonary function testing. And I think this is something that would possibly happen, and AI, this paper actually looked at both the pattern and the diagnosis using AI and showed that in both of this, AI software actually outperformed the pulmonologist interpretation as far as the pattern and the diagnosis was concerned. So what can be the future goals? I think we need to look at inter and intra-laboratory variability. We should have, like we're having today, formal certification program, because as Dr. Nagarjun mentioned, currently there is a lot of laboratory variation in terms of the technique that is being used, the curve that you see. Sometimes the curve is not proper, the starting of the lung function has not been proper, or there's been a cough in between, or there's been an abrupt cutoff. So we need to really develop good certification programs. Standardization of reference equations is needed. We will probably need to look at other ways of looking at pleural pressure, looking at esophageal balloons, transcutaneous technology, which will actually look at not only pulse oximetry, but also look at your PCO2 and be able to use a technology which could help in diagnosing CO2 narcosis. And non-invasive cardiac output measurement is something else which could also add on to the armamentarium as far as pulmonologist is concerned. So I'll stop here. Thank you very much.
Okay. Because it's a keynote address, I think we'll not have any questions and we'll move on to the next session. We thank Dr. Guleria sir for spending his valuable time coming here and sharing his wealth of knowledge and experience over the decades with all of us. So I'll request people to come and take over the proceedings.
Okay, moving on, we'll go ahead with the third session on DLCO. I would like to call the moderators for the session, Dr. K. Anil. Okay. Sir is a consultant pulmonologist at Times Hospital at Vijayawada. I would also like to call Dr. Satish C. Reddy, sir. Sir is a consultant pulmonologist at Yashoda Hospital's Malakpet. Due to time constraint, I request the speakers to limit the talk to 20 minutes, and any questions will be taken at the end of the session. We could have the question and answer sessions during the demonstrations. I would request the moderators to kindly welcome the speakers and continue with the session. Thank you.
Thank you, Arjun, for the opportunity. And now I'd like to introduce Dr. P. Arjun. The session is on DLCO right now, the third session. So Dr. Arjun has done his MD DNB Pulmonary Medicine, and he's a consultant at KIMS Health and SP Fort Hospital, Trivandrum. So he's got a wonderful track record, which you all can see there. So Arjun, it's all yours. So let us see what new things we can learn from this topic, DLCO right now.
Good afternoon, everyone. At the very outset, let me thank Nagarjun for the opportunity. In fact, actually, Professor Dhruv Chaudhary was supposed to deliver this lecture, and I am a last-minute substitute for him. So in the next 10 minutes, what I'll quickly do is to give a broad outline about the physiology of DLCO and set a stage for Professor Chabra to talk about the technical aspects. And then I'll be back again to discuss the clinical relevance and clinical applications of DLCO in day-to-day clinical practice. So what is DLCO? Now, basically, DLCO measures the ability of the lungs to transfer gas from the inhaled air to the red blood cells in the pulmonary capillaries. So that is what basically DLCO is all about. We talk a lot about DLCO, but it is a vastly poorly understood test and poorly underrated test. But in fact, it gives us a lot of information about the lung disease that the patient has, and even the site of disease that the patient has. So basically, it intends to provide an estimate of the rate at which molecules move by diffusion from alveolar air to the pulmonary capillary flow. But what we need to understand is that the term itself is not an appropriate term. When we talk about diffusion capacity, it's not a capacity. Some people tend to call it the transfer factor, which is used in many centers, particularly in the European countries. The US, people in the US tend to call it diffusion capacity. In the Europe, it is mentioned as transfer factor. But in all correctness, transfer factor is the right word, Because number one, we do not measure any capacity here when we talk about diffusion capacity. It is something which is done at rest, so it's sub-maximal. And there are many processes other than the diffusion which contribute to the entire test and the results that we get. So the appropriate term is indeed transfer factor, or TLCO as it is commonly called. But what we basically do when we do a diffusion study is we measure the volume of a diffusion limited gas. Mostly what we usually use is carbon monoxide that will diffuse through the membrane at each minute for a partial pressure difference of 1 millimeter of mercury. So the result is mentioned as ml per minute per millimeter of mercury at standard temperature and pressure. So basically what happens is, this is the air in the alveolus, where we find that there is oxygen which is predominantly there, which moves across the alveolar epithelium to the interstitial space through the capillary endothelium, gets into the blood, and then gets into the RBC, and then it binds to the hemoglobin that is present in the RBC. So there are many factors which determine the diffusion capacity test or the transfer factor. Number one is the area of the alveolar capillary membrane. The more the area is, the more better the diffusion is. For example, in conditions like pneumonectomy, where the area of capillary membrane is lost, we find that the diffusion capacity is less. The thickness of the membrane. Very typically what happens in interstitial lung disease is there is thickening of the membrane, so the DLCO tends to fall. The driving pressure that is created by oxygen across the gas in the alveolus to the blood in the venous capillary. The blood flow in the pulmonary vasculature, again, is very important. In conditions like pulmonary embolism or pulmonary vascular disease, we find that the blood flow is less, and naturally the DLCO becomes less. The area of RBC membrane, the more the RBCs, better is the diffusion. In anemia, what happens? There is a decreased DLCO diffusion. And of course, the coupling with the hemoglobin. So basically, what diffusion capacity or the transfer factor tells us that it's a window to the pulmonary microcirculation. There are structural factors which are involved in it. There are functional factors which are involved in it. So what are the structural factors? Number one is the lung gas volume. Number two is the thickness and area of the alveolar capillary membrane. Number three is the volume of hemoglobin in the capillaries that supply the ventilated alveoli. There are a lot of functional factors as well. It depends on the ventilation and perfusion that is happening, the composition of the alveolar air, the diffusion characteristics of the membrane, which is perhaps the most important functional factor, the concentration and binding properties of hemoglobin, and carbon monoxide and oxygen tension that is present in the alveolar capillaries. Two major factors have to be considered when we speak about DLCO measurements. Number one is what we call the membrane conductance, measured as DM. And number two is what we call as the theta VC, which is the carbon monoxide and hemoglobin reaction, how carbon monoxide binds to hemoglobin. So they are actually identified by two things. One is the reaction rate, which is mentioned as the Greek letter theta, and the pulmonary capillary blood volume, which is mentioned as VC or QC. So we have an equation here which tells us that diffusion in the lungs, which is 1 by DL, is equal to 1 by DM, which is the membrane conductance, plus 1 by theta VC. So whatever happens here is the result of the interaction between all these factors. Now there are many ways by which DLCO can be measured. I will not be speaking about this because Chabra sir is going to talk about this. But what we need to understand is the one which we commonly use in our day-to-day clinical practice is what is called the single breath hold technique. Now there are many, what are the gases that are used for transfer factor? So when we talk about diffusion, DLCO and the diffusion study, there are 3 or 4 gases which are important. Number one is of course carbon monoxide, which is the most important gas which we use to study. We also use a tracer gas. It can be helium, it can be methane. So what the tracer gas basically tells us is it will give us an idea of the alveolar volume. And that becomes important when we talk about analysis of the DLCO report. Then the rest of the gas is a combination of oxygen, FiO2 of 21%, and the rest is nitrogen. And this basically assumes that there is no carbon monoxide in the blood of the patient before the test is done. That is important when you do a DLCO test in a patient who is a smoker. ideally the patient has to stop smoking 24 hours before the test is done, so that it virtually removes the existing carbon monoxide. So if carbon monoxide is already present, it would have bound to hemoglobin, then binding of further carbon monoxide will be impaired, and so we will get a falsely reduced diffusing capacity. Now, why do we use carbon monoxide and not any other gas? There are many reasons for this. Number one is its affinity to hemoglobin is 230 times more than, and so that there is no pressure buildup in the pulmonary capillary bed. Number two, it is easily soluble through the pulmonary membranes. And there are other reasons, as like it exactly follows the same pathway as oxygen. It is easy to measure in the lab setting, rapidly absorbable, it's cheap and easily available, and at low levels, that the 0.3% that we use, it is non-toxic as well. Any other gas can be used. What is coming up in a big way is the diffusion of nitric oxide. So, and now we have something which is called a DLCO by DLNO by DLCO ratio, which is something, an advancement that is happening in the measurement of diffusing capacity. So basically, what is the advantage of using nitric oxide along with carbon monoxide? We saw this equation earlier, 1 by DL is equal to 1 by DM plus 1 by theta VC. Now, it has been shown that DLNO reflects, it's more a very good reflection of the membrane conductance, whereas DLCO shows us a better ability of the theta VC. So when we combine both of this, we get a much better and much accurate measurement of diffusing capacity. What is the clinical relevance of this? I'll come to when I give my next talk. So this is a scheme of gas concentration. What we basically do is you ask the patient to do a few tidal breaths, breathe out to residual volume, then breathe, make a quick breathe to total lung capacity, hold for about 10 seconds, and quickly exhale out. So this is what basically happens. And the first part of the exhaled air is discarded because that basically comes from the dead space. And the rest of the gas is analyzed for the tracer gas, could be helium or methane, and carbon monoxide concentration. Now this is what exactly happens when you do a DLCO test. Carbon monoxide goes and mixes with the residual volume. Then it reaches the alveolar membrane, diffuses across the membrane, crosses the RBC membrane, binds to the hemoglobin, and then when the subject exhales out, the exhaled sample is analyzed. So this is the single breath maneuver technique. Professor Chabra will be talking about it, so I'll not waste time over this. Certain precautions need to be done. As we saw in spirometry, 8 tests are what is maximally recommended. Here is no more than 5 tests are recommended, basically because you expose the patient to more and more concentrations of carbon monoxide. And there should at least be a 4-minute interval between 2 subsequent tests. Also, as I said earlier, patient should not be smoking for the past 24 hours. And if the patient is on oxygen, that has to be stopped for 15 minutes prior to doing the test. For patients having an obstructive lung disease, you have to give sufficient time to exhale out to the residual volume. And the inhalation should always be maximal. A submaximal inhalation will give a falsely wrong DLCO. Certain adjustments need to be done when you make the calculations. Most important one is hemoglobin. Anemia can cause a reduction in DLCO values, so always make, do the correction for hemoglobin. And then for carboxyhemoglobin also. So certain terminology are used in diffusion studies. Number one is DLCO, which is otherwise called the transfer factor. And there are 2 important components from a clinical perspective. Number one is VA. VA basically tells us about the alveolar volume, or the number of units, that alveolar units, which are contributing to gas exchange. And that, as is told earlier, is measured using the tracer gas, helium or methane. And then the most important thing is what is called the KCO. KCO tells us the efficiency of alveolar transfer of carbon monoxide. So when we talk about interpretation, we will speak about this in a more detailed way. And often in many reports, you don't get the value of KCO. It's always mentioned as DLCO over VA. So there are a lot of indications to do DLCO. I will just prime and stop here. It can be used for differential diagnosis of dyspnea. We can ideally find out whether it's an obstructive disease, whether it's a restrictive disease, or even a pulmonary vascular disease. For screening of disease, you can pick up early ILD. You can pick up early emphysema if you do a DLCO. It's important in follow-up also, follow-up and response to treatment, especially in interstitial lung diseases and progressive pulmonary fibrosis, DLCO can be used. It helps us predict survival in patients with in patients with interstitial lung disease as well as in COPD. And it is a very important component of the pre-operative assessment of before we subject a patient to a lung resection for pneumonectomies and lobectomies. So these are my take-home points from this talk. DLCO ideally should be called a transfer factor or TLCO. Preparation discordance is one of the main reasons for faulty reports, and a faulty report actually makes us come to wrong conclusions. So ensure that the preparation is adequate, the maneuver is done properly. Patient cooperation is extremely important, especially for the intake of breathing to total lung capacity and for the breath hold. And multiple lung tests should not be performed in a day because which stands a risk of carbon monoxide toxicity. And it, as I said, it can be used for diagnosis. It can be used for follow-up. It can be used for differential diagnosis of pulmonary disease and also to prognosticate many lung diseases. And it takes less than 10 minutes, it doesn't even take 5 minutes to do a test properly, as we'll see in the afternoon. So you need not schedule it for a particular day. You can do it at any point in time, and you can gather valuable information about the disease that the patient has. Let me stop here, and thank you very much indeed.
Thank you, Arjun. That was a simple and elusive talk, and anyway, we are going to learn more from you in the stations. Thank you so much. Now we have the second speaker.
Next, invite Chabra sir for after understanding the physiology of DLCO. Next, moving on to methods of estimation and technical standards of DLCO estimation. So over to you, sir.
So good afternoon, and I'm glad Dr. Arjun's talk preceded mine, and most of the things that I wanted to cover, he has already covered. Little bit what I have to reinforce, I'll add that, so that will save time also and skip. So I will talk more about estimation. Interpretation again, Dr. Arjun will be taking. Assess the gas exchange, that is a transfer of oxygen from alveolus into the capillary and binding with the hemoglobin. So that is the only indirect way by which we can do it. Again, discuss what are the different factors which will affect the transfer of gas from the alveolus to the blood. So ultimately it's how much lung expansion is there, what are the properties of the surface through which the gas has to diffuse through, and the pressure gradients on the two sides, and the properties of the gas. Methods, the only method which is standardized is single breath. That is the one which is widely used and has clinical applications, most well studied. Other methods used sparingly, only in certain circumstances, only as research applications. The only diffusion capacity measurement that you will be doing, at least for the machines that are available, is single breath DLCO, written as DLCO, single breath. Now, why CO again discussed? Although we are measuring oxygen, we cannot measure oxygen because there is oxygen on the other side of the alveolus also. So that measuring oxygen in the capillaries is difficult. So carbon monoxide is a very good substitute and binds the same way as oxygen does to the hemoglobin. So it is the gas of choice for measuring DLCO. The steps of movement, again, Dr. Arjun has described how the carbon monoxide moves from the alveolus across the alveolar capillary membrane, enters into the RBC, binds with the hemoglobin. So these are the different path obstacles that the gas may face, and pathologies all along this route can affect the measurements of DLCO. These components were discussed, so, and this diagram makes interpretation easier. So broadly, you can now make out that anything which goes wrong on this side of the alveolar-capillary membrane, that is the expansion of the lung, the volumes, the properties of the alveolar-capillary membrane, or changes in the hemoglobin or the blood volume, these are going to affect the measurement of DLCO. Components, what we measure is diffusion capacity as a whole, because right now DM measurements are not standardized, and again nitric oxide is one method, but that is yet to be standardized. So what we measure are combined properties of this entire path. Terminology again discussed. In America they call it DLCO, Indians follow Americans, so we also call it DLCO, Europeans call it transfer factor. The most important equation for interpretation is this one, KCO into VA is equal to DLCO. So what we actually measure is KCO and we measure VA. So any condition which alters KCO will alter diffusion capacity. Any factor that changes VA will affect DLCO. So KCO is the efficiency of gas exchange and VA is the alveolar volume as already explained. So what we do in the measurement of diffusion capacity in the test is that we measure KCO and VA and calculate DLCO. Units are very important, and this must be understood because very often you come across two reports from two different labs which are widely different, because diffusion capacity is a poorly understood test, and this thing is very often ignored as what are the units in which we are explaining the terminology. You could have a value in one report saying DLCO is 25, another lab reporting DLCO is 8. Both are correct, but the units are different. So in the ATS terminology, it is ml/CO per minute per millimeter mercury. European units are different. They have a report in SI units, then you multiply it by 2.987 and you will get the ml/CO per mm unit. So this is an important conversion which we should be aware. Indications again discussed. So broadly, disease like COPD, because emphysema without a morphological diagnosis can be diagnosed by only two ways, either a CT scan picture of emphysema or impaired diffusion capacity. Important differential diagnosis from asthma. There are patients who of severe asthma who resemble COPD. The vital difference is that in asthma diffusion capacity is not impaired, in emphysema it is impaired. Then about ILDs, it has been discussed. We evaluate, grade the severity, we follow up. A recent terminology is progressive pulmonary fibrosis. So some of the non-IPF ILDs, as they progress in their natural history, if the diffusion capacity is falling by more than 10% within a period of 1 year, we use the term progressive pulmonary fibrosis, and antifibrotics can be added even in non-IPF ILDs. Then evaluation effects of chemotherapeutic agents which affect the lung. In lots of connective tissue disorders with involvement of the lung, like RA, SLE, PSS, again, whether parenchyma is involved or not, that can be evaluated before the lung disease actually manifests. Then one very important indication is the pulmonary vasculopathy. And I had presented one case in discussion of spirometry, where spirometry was normal and DLCO was reduced, and that was a case of primary pulmonary hypertension. Then recurrent thromboembolism. So, and now it is easy to understand why pulmonary vasculopathy will also lead to impaired diffusion, because we have got diseases on the alveolar side, diffusion in the path of transfer, and then disease in the blood and the blood volume. So all these can affect diffusion capacity. Then evaluation of pulmonary hemorrhage. Blood catches carbon monoxide, so it will increase. Pneumocystis, although there are better methods of diagnosing pneumocystis infection, but it is given as one of the indications. Contraindications, very few. carbon monoxide toxicity were not very common in clinical situation, because when we do the test, we use a gas mixture which has less oxygen than our normal FiO2 in the normal air. We use about 18% oxygen. So if a patient already has hypoxemia, his saturation can go down further. So that is one precaution that we have to take, that patient should not be having too intense an hypoxemia. Some of the relative contraindications, because the test requires performance of a maneuver as per instructions, so the patient should be in a position to understand how he has to breathe. So should not have any problem of confusion or muscular incoordination. Then orofacial problems. No leaks are allowed. So the mouthpiece should fit properly. So dentures or any facial abnormality which would prevent. Preparing the patient is very important. Patients are advised not to take a large meal on the day of test, not to do vigorous exercise on the day of test, not smoke, because these would alter the test results. DLCO is very difficult to measure in very, very small lungs. As the lung volume shrinks, so in patients who have got very advanced fibrosing diseases, where the vital capacity has come down to 1.5, the accuracy of the result becomes a little suspect. Then, like we talked about quality control in spirometry, this is important, probably even more important because the equipment is more complex. So the technician must understand how is to calibrate the equipment. And there are more parts of the equipment to be calibrated rather than just the spirometer alone. So a qualified operator who is properly trained is very, very important. When we do the test, there is a period of breath holding, which I will be coming to. So at that point, it has to be relaxed breath holding, because if we try to breathe in or breathe out against a closed glottis, the intrathoracic blood volume will change. So that will change the pulmonary capillary flow. So that can affect measurement of DLCO. Then infection control is one issue which is true for all kind of PFTs. Talking about equipment which we will be seeing in the afternoon, so just quickly going through that. All systems, they have a source of test gas, which can be a cylinder or can be a bag. There is a method for measuring the inspired and expired volume, because in the procedure we have to inhale air, hold breath and breathe out. So we should be able to collect that gas which the person is breathing in and breathing out. And then we require gas analyzer. Now we are using so many gases in this. There are tracer gases, there's carbon monoxide, oxygen is there. So there are multiple gas analyzers. That is why the cost of the equipment goes up tremendously as compared to a spirometer. Then maintenance of the machine, especially the analyzers, that is a very, very meticulous job of the technician, and he has to take care of the machine just like one takes care of one's car if you love it. So this kind of standardization is required for every component of the machine. Otherwise, getting a wrong result with diffusion capacity is so easy. So quality control is therefore even more important. So how the test is performed, for any lung function test, it is very important to give a visual demonstration. So best is that when one person is performing the test, you call in the next person to watch how the test is being done, because that is the best way to teach a patient. So technician has to give a demonstration. The test is performed in a sitting position, comfortable room conditions, a mouthpiece tightly fitting, and a nose clip is required because it's a mouth breathing. If the test has to be repeated, then we wait for at least 4 minutes. In normal persons, in patients with lung disease, can maybe an even longer wait. The reason is that when a person breathes in carbon monoxide, some of it will be in the circulation. We assume during the test that there is no carbon monoxide in the blood. So that has to be washed out completely before the test can be done. So the preparation of the patient already discussed. Now one point about bronchodilators. Usually the sequence of testing in a lung function laboratory is spirometry first. If you have to do lung volumes, then lung volumes next. Then we give a bronchodilator and then do diffusion capacity test. And then finally, post-bronchodilator spirometry. Because the lung has to be maximally expanded, so bronchodilators can be given before that. patient starts with a tidal breathing and then does an unforced exhalation to residual volume. That is, he completely breathes out and reaches the residual volume. From that point, the device will be connected to the source of the gas. So there is a valve which moves, and now the patient is connected instead of atmospheric air into the machine, into the inspired gas mixture. So the patient breathes rapidly, a full breath in, and reaches total lung capacity. So these are two important points, that the patient must exhale out completely to residual volume, then breathe in maximally and reach total lung capacity, then hold the breath and for a specified time, which is usually 9 to 11 seconds, and then quick exhalation. So these have to be controlled by the operator, and there are criteria set for how much the patient has to inhale, what is the breath holding, and how he has to exhale out. The gas mixtures, again, already shown by Dr. Arjun. So the gas is carbon monoxide, which is 0.3%, which is a non-toxic concentration. Helium, methane, or neon, different manufacturers use different systems of tracer gas. Oxygen is around 18%, less than what we normally breathe, and balance is nitrogen. So this is graphic representation of the test. The person breathes out to residual volume and then takes a deep inspiration. When the patient reaches total lung capacity, the machine automatically uses a shutter to stop the patient's breathing. So that is breath holding, no breathing from that point onwards for about 9 seconds, and then the patient breathes out. When the patient breathes out, the initial part is coming from the large airways or the conducting airways, so that is dead space, so that is washed out. Subsequently, the air that comes out, that is the alveolar sample, that is taken. So we analyze the exhaled gas sample. The inspired gas we already know because the composition is written, but still the gas mixture is passed through the analyzers. So the machine will analyze the inhaled gas, exhaled gas. It will measure the time. It will measure how much inspiration has been taken. From these parameters, the calculations are carried out. Now there is more breath holding than the actual period of breath hold, because when the patient is breathing in, diffusion starts during inspiration itself. When the patient is breathing out, even at that point, some bit of diffusion is taken place. So part of inspiration and part of expiration is added to the breath holding time. So about 30% of the inspiratory time plus half of the expiratory sampling time is added to the breath holding time. This is the standard method for calculation of breath holding time. So the sample is collected in the expired gas. So now you can understand that there are valves in the machine which will move depending on which state of breathing the patient is in. The patient is breathing out, it is open to atmosphere. Patient starts to breathe in, it connects to the inspired gas mixture. Patient breathes out, dead space goes into the atmosphere. Then sample into the expiratory bag. Now calculations are extremely difficult. Even if you are a good mathematician, you cannot do it manually because lots of logs are involved in this, natural logs, because the decay of carbon monoxide from the alveolus to the capillary is exponential. It's not linear. So these are difficult calculations. So that is why you require a computation. Now, broadly, there are two calculations which I mentioned earlier. The rate constant for alveolar capillary carbon monoxide transfer, essentially how much carbon monoxide is going across the alveolar capillary membrane and reaching the hemoglobin and combining there. So that is all combined into one factor called KCO and the alveolar volume. So essentially our calculations will be computing KCO and alveolar volume. So these are the different gas analyzers. Now about gas analyzers, they are sensitive to carbon dioxide and water vapors. So before the gas goes into the analyzers, there are scrubbers in the machine which will remove carbon dioxide and water vapor. So the alveolar volume is calculated, then KCO is calculated. So I will not go into detail of these because these are extremely like these kind of calculations. So very difficult to do manually. The computer will do it for you, but give you the KCO and the VA finally. So like in spirometry, we have got what are known as acceptability criteria. The most important is that the volume that we inhale should be around 85 to 90% of a previously measured vital capacity, because the test is done at total lung capacity. We measure diffusion capacity at maximum lung inflation. So the spirometry value is known earlier. So VI or inhaled volume should be 85%. Then breath holding should be at least 10 seconds, so 10 plus minus 2. Relaxed breath holding, no Valsalva or Muller maneuver. Expiration should be fairly fast, less than 4 seconds. So these are the 2017 ATS standards. Then repeatability criteria. Diffusion capacity is more variable than spirometry parameters, so a wider difference between two measurements is allowed. So in the same session, repeated measurements, 3% difference in normals and 4% in patients with obstruction is allowed. Ideally, a report of two mean measurements, the two repeatable measurements should be given. Then there are certain corrections which are done. We must have the patient's hemoglobin value with us that is fed into the software, because the hemoglobin affects diffusion capacity. So we express the measured DLCO as if the patient's hemoglobin is normal. Then there is correction for carbon monoxide. Ideally, we should be measuring carbon monoxide with a co-oximeter. Otherwise, we take it as 0. But if it is, because carbon monoxide is always there in the air, so it is always better to correct it. Then altitude, there is called correction for altitude that is required. So when these are corrected, then we call it as a corrected DLCO. So in a reporting format, this is how the data is reported. We have unadjusted DLCO that we have calculated KCO into VA. Unadjusted is unadjusted DLCO. Then adjusted for hemoglobin, carboxyhemoglobin, and altitude. Then predicted and percent predicted DLCO. So you require prediction equations for DLCO. Then predicted and percent predicted KCO, the alveolar volume. So likewise for spirometry, same kind of columns, predicted values and percent predicted value. VI, the inspired volume. Now about the equations. In spirometry, we have had equations for last 30, 40 years. In 2014, my equations were published, which are based on the recent standardization. For diffusion capacity, these are the only equations from India. So these I had published in 2016. So these are now available in most of the machines which are available. So our own measured values should be compared with these values. And just like in spirometry, there is a standard error of estimate also given. So same way, lower limits of normal can be calculated. Same way, predicted minus 1.645 into standard error of estimate will give the lower limit of normal. So any value which is less than lower limit of normal will be abnormal. Otherwise, as a rule of thumb, we take it as 80%. So before I finish, just a quick word about what is important in interpreting. The final equation is KCO into VA is equal to DLCO. So any condition that affects the KCO will affect diffusion capacity. Any condition that affects VA will affect the diffusion capacity. So KCO can be affected by any change in the membrane properties, the thickness, the surface, any pathology therein. Theta, the reaction rate, which is constant. Blood in the capillaries. So permicirculation therefore affects diffusion capacity. Then alveolar volume can be affected by both obstructive conditions as well as by restrictive conditions. So therefore, the diseases which can alter diffusion capacity are wide. DLCO is reduced if KCO is reduced. DLCO is reduced if VA is reduced, or it can be reduced when both are decreased. So in interpretation, the key question is that when DLCO is reduced, is it because of reduction in VA or is it because of reduction in KCO or both? Sometimes the changes in VA and KCO are not matching, so we can have odd kind of results, but ultimately DLCO will be affected by these two terms. The 2017 standardization statement gave a classification for severity of DLCO. So when it is more than lower limit of normal, that is normal. Impairment between 60% to lower limit of normal is mild impairment of diffusion capacity. Moderate is 40 to 60%, and severe is less than 40%. So that's about diffusion capacity, and we'll have a demonstration in the afternoon. We'll have some cases from Dr. Arjun to complete the session. Thank you very much.
That was excellent presentation, sir. Next, moving on to interpretation of DLCO reports in clinical context. Welcome, Arjun, sir.
Can I have the slides, please?
This one, sir?
And this one. It's moving. Do you need to activate this or something?
No.
Resume slideshow. Will it work now?
No, sir, I'll just close the other ones. It's getting stuck because of that.
Everything is coming together. This one, new folder. Edit, yeah. In the next 25 minutes, let's quickly go through how we can apply this knowledge that we have gained from the previous two lectures in our day-to-day clinical practice. So, as I told earlier, DLCO is a very important test, grossly underperformed, poorly understood, and it has lots of value in when we properly apply it. So what I'm going to do is to structure my talk like this. We will start by looking at the indications which we have already done. We will look into the components which Chabrasara has beautifully explained. We will try to develop an algorithm which perhaps is the most important thing that we need to do to understand how to interpret a DLCO report properly. Speak about the severity grading. Then we'll come to certain clinical scenarios where how we can use this. And finally, end by looking into what is new in the field of DLCO interpretation. So these are the sort of cases that we usually get in our day-to-day practice. This is a 67-year-old female who is a non-smoker who presents with dyspnea on exertion with dry cough for the last 1 year and has not taken any treatment so far before she comes to you. When you look into the lung function, you can see that the FEV1 by FVC ratio is normal, basically telling that this is not an obstructive disease. You find that the FVC is low, which perhaps might be an indicator that she might be having restriction. But of course, you need to confirm with lung volumes. The lung volume, you can see here that the total lung capacity is 48%. So TLC less than 80% means that we are dealing with a restrictive lung disease. Then you have other data like DLCO, which says that DLCO is reduced to the tune of 42% and the KCO is normal. So when we have a report like this, there are certain things that we need to ask ourselves. What more information do we need? What is the diagnosis? What is the pathology? And more importantly, whether we can pinpoint where exactly the pathology is in the lungs. So that is what a properly interpreted DLCO report will help us understand. We will skip this because we have already spoken about the indications to do a DLCO. We have seen this as well, so we'll not waste time over this. But this is sort of a report that you usually get in your practice. You get all the dynamic volumes on top, you get the static lung volumes as well, and then in between sandwich you find certain values, which are the diffusion parameters. So when we talk about the report, as Chabra sir has mentioned, you get all this data. You have the unadjusted mean measured DLCO. You get the DLCO by VA, which we call the KCO. Then any adjustments which have to be made mandatorily, particularly hemoglobin correction has to be done. And then we get the VA also. But before we start interpreting a DLCO report, it's very important, like we looked into the flow volume loop, to see whether the patient has performed the breath hold properly. So for instance, in this, you can see that so many things could be possible. A slow inhalation, a transient overshoot beyond what the patient should have hold, and stepwise inhalation, and fast rapid maneuver exhalation. All this will in fact give you wrong values about DLCO. So that will make the interpretation even more difficult. So once you have you are satisfied that the maneuver has been properly done, the next thing that you should, before you go on to interpret, is to revise this equation. It's a very, very important equation, which says that DLCO is equal to VA into KCO, which basically tells us that DLCO will be low if VA is low, DLCO will be low if KCO is low, and DLCO can be low if both VA and KCO are low. So this is a very, very important equation which we should always keep in mind when we interpret a DLCO report. So the first thing, first of the two parameters is the alveolar volume. So what does the alveolar volume tell us? Basically, it tells us the amount of ventilation that has been happening and the alveolar and the area that has been ventilated properly. So what is important here is a major learning point that we get from this is, normally, as Chabra has said, VA is always proportional to the total lung capacity. So VA is about 0.8% of the total lung capacity. So when the VA is normal, that tells us that the total lung capacity is normal. And indirectly, it tells us the VA is normal. We are ruling out a restrictive lung disease. So this is a very important caveat that one has to keep in mind. The second component is the KCO, the transfer coefficient. Basically, it tells us how the gas exchange unit is functioning properly. And we have conditions where you can get a low KCO. Low KCO can be because of many reasons. It can be because of a parenchymal restriction. Typical example is an interstitial lung disease. Low KCO can happen because of pulmonary vascular abnormalities. Classical example is pulmonary hypertension or pulmonary embolism. Low KCO can happen if there is a right to left shunt in the somewhere happening, either in the pulmonary circulation, like an AV malformation, or in hepatopulmonary syndrome in patients with advanced liver disease. And in obstructive diseases also, like emphysema, you find that the KCO is low because there is destruction of the alveolar capillary membrane is destroyed, and hence the KCO becomes low. So these are the conditions where KCO is low, and these can all contribute to a low diffusion capacity. There can be conditions where the KCO is high as well. So this is again important. KCO becomes high in two groups of conditions, and both of them start with an extra. You can have extra parenchymal restrictive diseases like neuromuscular diseases, or you can have extra hemoglobin. This extra hemoglobin can either be in the circulation or outside the circulation. In the circulation is intravascular increase in hemoglobin, as we typically get in polycythemia. And extra hemoglobin is what you get in pulmonary alveolar hemorrhage, where the blood collects in the alveoli. So in extra parenchymal restrictive diseases and conditions where there is extra hemoglobin, the KCO tends to be high. And in some of these conditions, not all, as we'll see later, especially when there is extra hemoglobin and the KCO is high, you get an increased DLCO as well. But in extra parenchymal restriction, DLCO will be low, and because of reasons which we will see soon. So when we put all these three things together, the DLCO, the KCO, and VA, we can identify certain patterns which will help us diagnose the cause of the lung disease. For example, let us talk about pulmonary fibrosis. What happens in pulmonary fibrosis? We know that the alveolar volume is reduced, VA is reduced. Early in the course of pulmonary fibrosis, KCO can be normal, but as the disease becomes advanced, the KCO also starts falling. So as a whole, the DLCO is reduced in pulmonary fibrosis. And the mechanism of why this happens is because of alveolitis or diffuse loss of alveolar units. Let us take neuromuscular disease. Again, it's a restrictive disease. You can see that what happens in neuromuscular disease is the VA is grossly reduced because of poor expansion. But what happens is there is an increase in KCO. But when we compare both this, the reduction in in VA is far more than the slight increase that happens in KCO. So as a whole, the DLCO becomes reduced. And the reason why the DLCO is reduced here is lack of alveolar expansion. Let us now talk about the third disease, pulmonary vascular disease. What happens in pulmonary vascular disease? As we know that the lung volume is normal, so the VA will be normal. But the KCO is low because of many reasons, because of the destruction of the capillaries or thickening of the capillaries and all these things. So as a result, because the KCO is low, the DLCO is reduced. And the reason here is microvascular involvement. And finally, in a condition like pneumonectomy, what happens? As we know that when the patient has undergone a pneumonectomy, the alveolar volume is certainly reduced, and this is because of discrete loss of alveolar units. So, but what happens is the same cardiac output of 5 liters now gets distributed to one lung which is present. So what happens is the KCO becomes more, you have a high normal KCO. But again, as in the case of neuromuscular disease, the decrease in VA is much, much more than the increase in KCO. As a result, DLCO is reduced. And the reason here is loss of alveolar units. So this is how, basically putting together the reasons, the patterns, you can make a diagnosis of what the underlying disease is. So this again tells us the same thing. So not waste much of a time talking about this. You should also know that there are conditions where the DLCO can be increased. Physiologically, you can get an increased DLCO following exercise or when you adopt the supine position. But pathologically, the more important causes are alveolar hemorrhage, polycythemia, and a patient with asthma who is in exacerbation. So these are the pathological reasons where you get an increased DLCO. So let us see how we can interpret the diffusion capacity result in a stepwise manner. The first thing that of course you have to look at is in the DLCO, whether the DLCO is normal, low, or increased. And always keep in mind this equation, DLCO is equal to VA by KCO, VA into KCO. The second thing that you look at is the VA. Once you look at the DLCO, the next thing that you have to look at is the VA. And ideally, VA should be within 5% of the total lung capacity, or 0.8% or 0.85 to 0.9% of the total lung capacity. If the VA is low, you have to suspect loss of lung volume, which can happen following resection, which can happen following neuromuscular disease, embolic disease, and even in fibrosis. The last thing that you look for is the KCO. And the KCO is reduced in various conditions as we spoke about. It could be an intraparenchymal fibrosis like ILD. It could be pulmonary vascular disease or anemia. So this is the stepwise manner in which you go about. The other important thing is to understand a ratio called the VA to TLC ratio. It's very, very important when we interpret a DLCO report. So when the VA is low, the next thing you have to look for is the VA TLC ratio before you go on to see the KCO. So VA TLC ratio, as we said, VA is always a subproportion of the total lung capacity. So what happens in an obstructive airway disease is there is a maldistribution of ventilation, so that the VA TLC ratio will be low. The total lung capacity will be normal, for example, in a patient with emphysema, but the VA will be low because the ventilation is poorly distributed. So you get a low VA to TLC ratio. On the other hand, in restrictive disease, this ratio is maintained. And because total lung capacity is reduced, VA is proportionately reduced, so that the VA to TLC ratio is normal. So a normal VA TLC ratio tells us that we are dealing with an restrictive lung disease. So when we put all these things together, we will be able to develop an algorithm like this. And this is something which all of you should know very clearly. Although it looks a bit busy, I will take you through it. So when we have a patient with low DLCO, the first thing that you have to look into is the VA. The VA can be normal or the VA can be low. Let us go to this part of the algorithm. If the DLCO is low and the VA is normal, then it inevitably tells us that the reduction in DLCO is because of a low KCO. Because we know the equation DLCO is equal to KCO into VA. Normal VA means KCO is low, and the conditions that typically causes a low KCO in the setting of reduced DLCO is pulmonary vascular disease. Other conditions you can get like an early emphysema, but the most common clinical scenario is a pulmonary vascular disease. On the other hand, the DLCO is low, and when you look into the VA is also low. The next thing that you have to look is the VA to TLC ratio. If the VA TLC ratio is normal, then we are in this part of the algorithm that tells us it is a restrictive lung disease. And then the next thing that you have to look for is the KCO. In the setting of a restrictive lung disease, as evidenced by a low VA and normal VA to TLC ratio, if the KCO is also normal, we are dealing with a intraparenchymal fibrosis or an intraparenchymal cause of a restrictive lung disease like a fibrotic lung disease. If the VA TLC ratio is normal, but the KCO is high, then we are dealing with an extraparenchymal restriction like a neuromuscular disease. So this is a very, very important concept, and based on this, we can not only diagnose a restrictive disease, but we can also pinpoint as where the restriction is happening, whether it is in the lung parenchyma or whether it's outside the lung parenchyma. So this again is an important take-home point. In a patient with a restrictive lung disease, where the DLCO is low, the VA is low, but the VA TLC ratio is normal, suggesting that it is restriction. If the KCO is low, you are dealing with an intraparenchymal cause of restriction, and if the KCO is high, you are dealing with an extraparenchymal cause of restriction. Then we come to this part, when the VA is low and the VA TLC ratio is also low, that tells us that we are dealing with an obstructive lung disease. Again, look at the KCO. If the KCO is low, the obstructive lung disease that we are dealing with is emphysema. On the other hand, if the KCO is high, we are dealing with a patient having an asthma exacerbation. This part we will leave alone because it's too complicated, but simply by looking at the KCO, low KCO tells us in an obstructive setting it is emphysema, and a high KCO in an obstructive setting tells us we are dealing with a patient who has an exacerbation of asthma. This is the grading severity. Chabra sir has already spoken about it. From a clinical, practical perspective, we can usually apply this 20, 40, 60, 80 rule, like what we use the 30, 50, 80 rule for gold classification. So normal, basically we can take it as 80 to 100, 60 to 80 is mild diffusion impairment, 40 to 60 is moderate, 20 to 40 is severe, and less than 20 you call it a very severe impairment. But for the postgraduate sitting here, from the examination point of view, this is what the examiner would expect from you. Normal is 75 to 140. This is as per the ATCRS grading. So 75 to 140 is the normal range of DLCO. More than 140, you say that the DLCO is high. And if it is less than 75, you say that the DLCO is low. Again, mild is 60 to 75. Then the others are same, 40 to 60 and less than 40. So from the exam point of view, 75 to 140 is the range that you have to answer. You can also apply the Z-score here. And based on that, you can find that if the DLCO is more than 140, you are dealing with a condition where the DLCO is abnormally high, like probably an alveolar hemorrhage or a polycythemia. With this background information, let us try to solve a few cases. This is an 84-year-old man having rapidly progressive breathlessness, bilateral reticular infiltrates with ground glass opacities, and spirometry suggesting a moderately severe restrictive disease. Certain values are given here, and whatever is mentioned as A indicates that the values are abnormal. You have the total lung capacity of 65, DLCO of 45, VA is 54, KCO is 68, and VA TLC ratio is 0.85. So whatever information we need to put into the algorithm are available here. But what I would advise all of you sitting here is, whenever you have a chart like, a report like this, the first thing that you look is at the total lung capacity. And any total lung capacity less than 80%, you are dealing with a restrictive lung disease. With this background information, let us see how we can apply this algorithm here. So let's put the values here and see how it goes. We know that the DLCO is low, it's 45, so it is low. Then the next thing that we have to do is put the VA. So VA again is low here, it's 54, it's low. Then we look at the VA to TLC ratio. VA to TLC ratio is normal. So that means that this is a restrictive lung disease, very good. So the next thing that we apply is the KCO. KCO again is low, and that tells us that we are dealing with the intraparenchymal cause of restriction like an interstitial lung disease. Very good. So this is how it goes, and the explanation that was given, the patient had reticular nodular opacities in the CT, and a restriction as evidenced by total lung capacity also tells us that we are dealing with a restrictive lung disease. So again, this is what has happened in this particular patient. There has been diffuse loss of alveolar units. That's why the VA is grossly reduced, and KCO is also low, so that the DLCO is grossly reduced in intraparenchymal fibrosis. Let us now go on to the second case. 59-year-old man, dyspnea MMRC score of 2 in the preceding 6 months, has a normal X-ray, normal spirometry showing a moderate and proportional reduction in both the FEV1 and FEC, and it's probably a non-specific pattern. So, and the values are given here. You have all the values here. You have the total lung capacity, DLCO, VA, VA-TLC ratio, and KCO. So again, let us apply this algorithm here. So let's start. So the DLCO is low. And again, as I said, always look at the total lung capacity, which is again 50%, which tells us that we are dealing with a restrictive lung disease. So VA is low. VA again is low. DLCO is low. VA is low. Then we look at the VA-TLC ratio, which is normal, 0.79. That means we again are dealing with a restrictive lung disease. So what do we do next? Look at the KCO. How much is the KCO? 145. So is it normal or abnormal? It's abnormal and grossly elevated. So that will tell us that this particular patient has a neuromuscular disease or an extra parenchymal cause for his restriction. So this is how, it's very easy if you understand the concept, have this algorithm in the back of the mind and approach the interpretation in a stepwise manner. So what has happened to this particular patient is because of there is incomplete expansion of the lungs because of the neuromuscular weakness. So the VA is grossly reduced. The KCO may be slightly elevated because of the maldistribution of circulation of the perfusion, but as a whole, DLCO is grossly reduced. This question has two parts. The first part was what happened to the patient earlier and subsequently what happened after treatment. 62-year-old woman with worsening dyspnea, cough, and chest pain in the preceding 6 months. MMRC score is 2 to varying between 2 and 3, has bilateral ground glass opacities. Spirometry suggests a mild restrictive pattern. So these are the values here. Total lung capacity is 67%. That means it's restriction. DLCO is reduced. The other values are also there, VA, KCO, and VA to TLC. Subsequently, what happened is this patient had an admission to an intensive care unit with a hypoxic respiratory failure and had prolonged invasive mechanical ventilation. And after the patient was discharged from the hospital, 1 month later, the patient does another DLCO measurement. You can see the values are here. Values have now substantially altered as compared to the previous one. So let us see how we will interpret this particular report. We'll look into the first part first, what the patient had in the initial part. So total lung capacity is reduced, so it's a restrictive lung disease. DLCO is also low, so we look into the VA. VA again is reduced, so that we are dealing with, next thing that we look for is the VA to TLC ratio, which is normal. It's 0.9. Anything between more than 0.85 is supposed to be normal. So again, we are dealing with a restrictive disease. Now let's look at the KCO, which is again almost on the normal thing. So this is another important caveat which I want to tell you. Because KCO is equal to DLCO by VA, if there is a proportionate reduction in DLCO and VA, KCO will be normal. Particularly in early interstitial lung disease, KCO can be normal. And a normal KCO will not rule out an interstitial lung disease. So this patient had an early interstitial lung disease earlier. Subsequently, after that hospitalization, ventilation, we find that the values have grossly changed. So let's apply the algorithm here once more. The total lung capacity has further declined, saying that the restriction has now become worse. DLCO again has become low. The VA is low. VA-TLC ratio is low. But now you look what has happened is the KCO has grossly increased. So now the patient has got another second cause of restriction which has come over the first cause. So here is a neuromuscular disease which has happened. In fact, this was a patient with lupus pneumonitis. That was the reason for the first mild restriction that the patient had, a parenchymal restriction. Subsequently, after ventilation, developed a critical illness, myopathy. So that is what has happened in this scenario. So by serial interpretation and going in a systematic manner, we can actually exactly find out what is really going wrong. So again, this is to highlight the fact that a normal KCO will never rule out an interstitial lung disease. Early in the course of ILD, KCO will be normal, and only subsequently the KCO will also start to drop. So this is another important learning point one has to keep in mind. Just because of the fact that the KCO is normal, never say that the patient does not have an interstitial lung disease. Next case is an 84-year-old man with LV dysfunction, severe LV dysfunction, 31%, long-term smoker, 11% emphysema seen in the CT. Spirometry shows a low FEV1 to FVC ratio before and after inhaling a bronchodilator. So these are the values here. You can see that the total lung capacity is 114%, which basically says that the patient does not have a restrictive lung disease. 80 to 120 is basically in the realm of normalcy. So let's again apply the same algorithm here. So the DLCO is low. Look at the VA. VA again is low. Then you look at the VA to TLC ratio. VA TLC ratio again is low, which again confirms that this patient has an obstructive disease which is going on. Look at the KCO. KCO is also low, which tells us that this patient has emphysema. So that is how we apply the algorithm to find out obstructive diseases as well. So what really happens in emphysema is there is the VA is reduced, KCO is grossly reduced because the alveolar units are damaged, and the DLCO becomes low. The next case is a 48-year-old woman, long-term smoker, who has a dyspnea MMRC score of 2, supposed to be suffering from COPD, but there is no proof of that. And the patient had a normal spirometry, but was branded as having COPD, and despite having a normal spirometry before and after giving a bronchodilator. So the values are here. So let's try applying the values here again once more. The total lung capacity is 91%, so we are not actually dealing with a restrictive lung disease. Then look at the DLCO, which again is low. So next thing that we look for is the VA. VA here is normal, 82. So the next thing that we look for is the KCO. KCO is reduced. So in this patient actually has a pulmonary vascular disease and not COPD. So that is what one should keep in mind. So that is the importance of applying this algorithm in the proper perspective. The last case is a 78-year-old man, long-term, has been having dyspnea for a long time. CT chest is consistent with COPD. Also shows pulmonary artery dilatation. There is airflow limitation before and after inhaling a bronchodilator. So these are the values here. So what does it tell us? The total lung capacity is 112%. That means basically it's not a restrictive disease. DLCO is grossly reduced. We look at the KCO, VA. VA is again low. VA to TLC ratio is also low. Then you look at the KCO, which is low, suggesting that this patient has emphysema. But what is more important is that there is a disproportionate reduction in DLCO as we expect. And so that reason could be explained that this patient, in addition to having emphysema, has pulmonary artery hypertension as well. So in pulmonary hypertension, vascular disease, basically what happens is the lung volumes are normal, so the VA will be normal, but the microcirculation is affected, so the KCO will be grossly reduced. And the reduction in DLCO is because of a reduction in the KCO. There can be certain conditions where you get an isolated reduction in diffusion capacity. In clinical practice, the most important one is anemia. And that's the reason why you should always apply anemia correction before you go on to interpret a diffusion capacity report. And the other thing, of course, is pulmonary vascular disease. Always when the patient has symptoms, spirometry is normal, and isolated reduction in DLCO, always think about pulmonary vascular disease. So much so that we can actually use a combination of a spirometry and DLCO report to know whether the patient has a pulmonary vascular disease. This has been suggested more for interstitial lung disease, particularly systemic sclerosis, and looking for this disproportionate reduction in DLCO. Now, what is meant by this disproportionate reduction in DLCO? Again, a very useful practice point. You look into the FVC by DLCO ratio. If the FVC to DLCO ratio is more than 1.6, that indicates the patient has pulmonary hypertension. Extensively studied and validated in systemic sclerosis, has been applied for other interstitial lung diseases as well, and now this is being applied in COPD also with a fair degree of success. So this is the learning point. FVC by DLCO ratio more than 1.6 indicates presence of pulmonary hypertension. DLCO can also be used to assess severity of lung diseases. pre-operative assessment DLCO less than 60%, that is a predicted post-operative DLCO less than 60%, means that the patient has a risk of developing complications following surgery. And if the DLCO is less than 50%, it is a predictor of desaturation during exercise. Now, what do the guidelines say? What about gold guidelines? DLCO has found mention of the recent guidelines since 2022. Says that if in a patient with COPD, if the DLCO is less than 60%, they are more bound to have increased symptoms, worsened health status, reduced exercise capacity, and increased risk of death. And in smokers without airflow limitation, DLCO less than 80% is an indicator that they are going to develop overt COPD very soon. And DLCO, in fact, should be done in all patients with COPD who have a disproportionate degree, symptoms are disproportionate to the degree of airflow limitation. What about IPF? We all know that this is used to follow patients with IPF when started on treatment. Serial PF, and if there is more than 15% decrease in DLCO in serial measurements, that indicates that the patient is not responding to treatment and the disease is progressing. And in progressive pulmonary fibrosis, this is one of the three domains. You have the clinical domain, you have the physiological domain, and the radiological domain. And in the physiological domain, absolute decline in DLCO more than 10% within 1 year indicates that the patient is developing progressive pulmonary fibrosis. We spoke about the DLNO-DLCO ratio. How can we apply it in clinical practice? It is very useful to pick up two conditions. One is a raised NO by DLCO ratio more than 110 indicates the presence of pulmonary vascular disease. And a low DLNO by DLCO ratio indicates that the patient has an interstitial lung disease. So this ratio will also help us identify between a vascular disease and an interstitial lung disease. So DLCO actually can be incorporated into this algorithm. I'm sure Dr. Deepak Talwar will be talking about this in his lecture tomorrow, so that we will get a comprehensive assessment of all patients who undergo a pulmonary function to know the real whether the patient has a disease, and if so, where exactly the disease is. So this is taken from UpToDate. This is something which I advise strongly all of you to go through it, which tell us conditions where DLCO is increased. Practically, the most important ones are alveolar hemorrhage, polycythemia, and asthma. Low DLCO with a normal spirometry, always think of pulmonary vascular disease. Low DLCO with restriction, with an obstructive component, think about emphysema. And low DLCO with restriction, think about interstitial lung disease. With this, let me thank you all for the kind attention. Pre-lunch talk is not an easy thing to do. And I bring greetings from KIMSL Trivandrum, and this is the wonderful team with whom I have the opportunity to work with. Thank you all once again. Thank you very much.
Nice presentation, sir. Any questions from audience? Sir, one practical question. Sir, how frequently you prescribe this DLCO in routine practice?
We usually do not prescribe DLCO in routine practice. Once for diagnosis of, we basically do a spirometry, and whenever there is a doubt of whether the spirometry is not giving enough information or we want more information, we do a DLCO. Also comes with the measurement of lung volumes in the body box, we do the DLCO. But more importantly, in patients with interstitial lung disease, we repeat this PFT and DLCO every 3 to 6 months, depending on whether there is any progression of the disease. And in patients who are put on chemotherapy, as well as patients who are on amiodarone, we basically do it once in 3 months to know whether they are developing drug toxicity.
Yeah, Dr. Arjun, one question. So this TLC, VA by TLC, so how the TLC is the one which is given in the DLCO report, or you take it from the body plethysmography and use it? Because the TLC
actually, it is calculated, there is an indirect way of calculating it, and we will get it in the DLCO report itself.
But normally what we have observed is that TLC, single bed TLC is not usually a very good indicator of...
slightly lower than the real total lung capacity we get with the body mass.
Impairment of VA will also cause impairment of TLC. So that single breath limitation will apply to both to VA and to TLC. The ratio will still be valid. But again, this is a very wide, spread is very wide in terms of interpretation. So you're not very sure that less than 0.8 is clearly indicating obstruction or not. But it helps.
So the last case you showed, which was emphysema with pulmonary artery hypertension, suppose a case of CPFE. Would I have a similar picture in that case?
almost similar picture in that case. But then, of course, you put everything in perspective, the CT findings, the clinical examination findings, and then interpret it. Always never interpret anything in isolation. Put everything together, and then you get the best out of it.
No, what I want to ask is, does the alveolar volume reduction is more
Thank you, everyone. I think it was a wonderful pre-lunch session. I shouldn't take much time, but some housekeeping announcements. So we'll all break for lunch, which will be served outside. So we'll again assemble at 3 o'clock. Yeah, 3 o'clock at the workstation. So workstations are there. As we go outside, I would request the delegates to divide themselves as per the number which is there on the delegate cards. This is a very important part. I would want as many of you to volunteer and do the test, so that only when you do the test, you know how exactly that it has to be done. So, and if you're not able to get a chance before 5:30, you can always come back, because we have the technical experts who will stay at the stations. So after 5:30 also, you can come back and have a feel of each of these PFT equipment. Thank you.